meet.
नहीं, but I'm doing it. I'm doing even the Manyata webinars ना, और मान्यता वेबिनार भी मेरे हफ्ते में 3 दिन हो रहे हैं, एंड डॉक्टर नीरज नोज की वो तो मतलब 1-1.5 घंटे का मैं क्लास लेती हूँ। तो
Patel sir, sir आ गया, can we start?
We can start.
Yeah. Shivani, can you please start the countdown so that I can officially welcome everybody?
Good evening, everyone.
Good evening.
Good evening.
So we are live on. So we are live on YouTube also. Yes, sir. Yeah.
Can you start sharing the slides so that I can officially welcome everybody, please? A very warm welcome to all of you on the Happy Learning Masterclass webinar series. This is the 207th edition with a special theme of Stillbirth, the Matter of Concern. This is in association with Sogok, Bhuj, Jamnagar, Rajkot, Porbandar and Junagadh societies. This webinar is curated by none other than the director of the program, Dr. MC Patel, sir. Let me officially first inaugurate the webinar, evoke the blessings of Lord Almighty so that I can formally welcome him. The inauguration slide, please, Shivan.
This right, ma'am?
Yes.
Yes.
Please click on it so that we have the prayer.
Yeah.
The volume is very, very low, Shivani. Thank you so much.
Yes. So, shall I start?
Yeah.
Yeah.
Okay.
You can show Dr.
Good
Patel
evening.
slide, please.
Yes.
It is my proud privilege to introduce our director for the program, Dr. MC Patel, sir, today. Sir has been the past vice president of Foxy. Sir is an active Rotarian, and sir is very active even in all the medical legal cases that we see in India. Sir is the go-to person. Sir has also been very actively operating in the Northeast societies free of cost. It is an honor to have you with us, sir, today, and I welcome you to welcome this August gathering and our chief guest, Dr. P.K. Shah, sir, today.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all on 207th episode of Happy Learning Masterclass.
Shivani, please stop sharing the slide, and then when sir wants to introduce sir, you restart sharing the slides.
And as mentioned prior, it is with Chogok activity and with Society of Bhuj, Jamnagar, Rajkot, Porbandar and Junagadh. And we have rightly selected subject for today's discussion, stillbirth, the matter of concern. And we are lucky enough to have Dr. P.K. Shah as a chief guest. He has kindly consented to be chief guest to bless us. Of course, he is always with us in any of our academic activity. Welcome, P.K. Shah, sir.
Thank you,
I
sir.
also welcome Dr. Sudhir Shah, guest of honor. He also always with us in any of our academic activity. Welcome, Sudhir Shah, sir.
Thank you very much.
One more good friend and guest of honor, Dr. Neeraj Jadhav, recently elected as a Vice President Foxy for 2027. So welcome Neeraj as a guest of honor. He is always with us in any of our academic activity. I also welcome all the learned faculty as far as this program is concerned. Dr. Jignesh Modi from Porbandar, Dr. Dipal Balodia from Jamnagar, Dr. Dhiren Taravia from Rajkot. They are going to chair very important session and speaker is Dr. Nita Sata and she is going to discuss etiology of stillbirth. I also welcome Dr. Hinaben Patel, Dr. Anand Bhagde and Dr. Devraj Badarka to chair second session, and it is also very important session. It will be dealt by Dr. Morjaria, and he is going to deal with fetal surveillance intrapartum. And one more set of chairperson, Dr. Gopal Hirani, Dr. Kuntal Jadeja, and Dr. Puneet Khatri. They will chair third session. But very important is today's panel discussion, and we are going to have very good panel discussion and moderated by Dr. Pankaj Desai, past president of FOXI. And we have two eminent guest faculty today in that very panel, Dr. Neelam Agarwal Madam from Chandigarh, she is President of Stillbirth Society of India, and Dr. Tamkin Khan Madam from Aligarh, she is Secretary of Stillbirth Society of India, and both are working a lot in that very field, and they are very right person to be in this panel as an expert panelist. They will have their own expert comment during panel discussion. I also welcome all the panelists, Dr. Devanand Parmar from Bhuj, Dr. Nalini Anand from Jamnagar, Dr. Piyush Vadalia from Junagadh, Dr. Hira Kodiatar from Porbandar, Dr. Jigna Ganatra from Rajkot, Dr. Deepak Bhagde, again he will also have his own expert comment. Deepak Bhagde from Jamnagar and good friend, my classmate also. Dr. Kartikeya Sastry from Rajkot and Jignesh Deliwala, treasurer of SOGO from Ahmedabad. And of course, my team, Dr. Monica Umardan, convener of this series, Dr. Monica Gupta from Alwar, she is a coordinator for this series, Nivedita Datta from Bokaro, she is also one more coordinator in this series, Dr. Satabdi Day from Siliguri, Dr. Deepika Logani from Delhi, and Dr. Megha Kamlapur from Kalaburgi. They all are coordinating, a coordinator of this series, and they are working a lot to have this type of interesting program on time every Tuesday at 6 p.m. So without wasting much of your time, I welcome you all the president and secretary of Joining Society and all the delegates. Thank you very much. Monica.
Dr. Monica?
I think she's not there. Now I request sir to introduce our guest of honor, PK Shah sir, Chief Guest PK Shah sir.
So it gives me immense pleasure to welcome and introduce Dr. PK Shah, good friend and always guide to us in any of our academic and other activities also. So PK Shah, past president of FOXI, and I was lucky when he was president, I was chairperson, Ethics and Medical Legal Committee FOXI. So he is a good administrator also, I would say. He had been I lost slide. Yes. Professor and Unit Head Department of OB/GYN LTM Medical College and LTMG Hospital Sion, Mumbai. Up to 2008, he was there and a very popular teacher, I would say. Past President FOXI, just I mentioned, past President of IAG, IFUMB, MOGS, AFTT, and past in Indian College of Medical Ultrasound, ICMU, from 2015 and 2016. Trustee
Sir,
Mumbai.
thank you.
Yes. So to conclude, he is good friend of all of us, and he's always good guide to us in any of our activity. Welcome, PK sir.
Yeah,
And
thank you.
have the blessings.
Yeah, thank you very much, sir, for making me a part of this webinar. And it's a great achievement that you are having more than 200 such webinars. I think it's a unique thing that has happened in Foxy. And it shows your deep-rooted interest in spreading academics all over India. So it's a Happy Learning Masterclass webinar series. And today's topic is stillbirth, a very dangerous thing to happen in practice. Most of them are not expected by any one of us. And it is nice to see that it is in collaboration with SOGOG and many societies of Gujarat. Dr. M.C. Patel, whom I know for so many years, is a program director, and I wish him success for the president's election in 2026.
Thank you, sir.
I also see Dr. Monica Umbadant, who is the convener, very important person for anyone to have in the team. So you are very lucky, sir, to have two Monicas with you.
Yes.
And it's nice to share this platform with three guests of honors, Dr. Neeraj Jadhav, Dr. Sudhir Shah, and Dr. Hemant Bhatt. It's nice to see that you have covered this particular topic in different ways, and that you have etiology of stillbirth going to be covered by Dr. Neeta, and intrapartum surveillance by Dr. Karthik. And you are going to talk about IVF, the aftermath. And the star programmer of the star performer of this particular event is Dr. Pankaj Desai, our good friend, who is going to be the moderator for the panel on unexplained IVFD. I think it's something very, very important for all the practitioners. And I'm sure you are all going to be benefited by today's webinar. Sir, thank you very much and wish you all the very best for involving me in this webinar, and I'll be with you all throughout. Thanks a lot.
Thank you, sir. Thank you for sparing time to bless us.
Thank you, sir. It is always an honor to listen to you and sharing the platform with you. I would now request Dr. Monica Gupta, madam, to please introduce our guest of honors for today.
Thank you, Monica. It is my proud privilege to introduce the guest of honor, Neeraj Jadhav, sir, with whom I have started my Foxy journey. He was my chairperson in the Sexual Medicine Committee, and I was a member. And when he received the Best Committee Award, I was with him on the stage, and that was a very proud moment for me as well as for him. Well, it was for him also, but it was a proud moment for me also. And he's a vice president elect. And over to you, sir, for your blessings.
Thank you, Monica, for your kind introduction. So, at the outset, I'd like to thank Dr. M.C. Patel, sir, for inviting me for this very good program on the stillbirth. I can see my regards to Deepak Bhai, Sudhir Bhai, regards PK sir, both Monica Gupta and Monica Ambarwant, Dr. Neelam, Dr. Deepika, Dr. Nivedita, hi everyone. So, dear friends, we all know stillbirth. We all, as an obstetrician, are worried about. Whenever patient nowadays very much fussy, so they will come with a small complaint, and we are worried what will happen, whether we will have a stillbirth or not. So, such type of program will give so much insight into our day-to-day practice, which will be very useful to every gynec. So thank you for making me part of this, and to all the organizers, Dr. M.C. Patel and both the Monica and Dr. Deepika and everyone for choosing these subjects, because it is a very important day-to-day subject we all have to deal with. And I would like to wish Dr. MC Patel for the upcoming election as the president of Foxy next year. We all are with you, and I'm sure that what, and also their friends in all over India will also, they will convince to vote for you. So I'm sure that next year we will make the cross the line. So I'm very hopeful for that. And so at the end, I would like to thank for making me part of this webinar.
Thank you. Thank you, Neeraj, for good wishes also and sparing time to bless the webinar. Yes, Monica.
Thank you, sir. Thank you very much. Now our next guest of honor is Dr. Sudhir Shah, sir. Please put his CV.
Shivani, please share Dr.
He's a
Sudhir Shah
senior
sir's slides.
gynecologist and IVF and endoscopic surgeon from the Rajkot, and he's a professor over there. He's a Jogi Foxy authorized. He has written 7 books for it under the JP Publications, and he has.
I request all others to please mute themselves so that
And
we
he
can
has
hear.
given the oration in the Ahmedabad conference on needle for NDVH. Over to you, sir, for your blessings.
Thank you very much to Monica. It has been a great day and great evening for me today to be here with friends and different faculties for this master webinar, learning webinar. As Dr. PK has rightly mentioned, it has crossed 200 webinars and it's a huge number. The number itself speaks how great work Dr. MC Patel has done in last 2 or 3 years. He has almost covered all subjects. Though he is a medical legal practitioner, he has covered most of the obstetrics, gynec, endoscopy, and other subjects via this masterclass webinar. It's a huge things. Everybody wishes him to be a President Foxy in coming years. He is having the election this year, and we must work very hard in our areas and see that such a nice person and knowledgeable person should be the president of Foxy. So, Dr. MC, I wish very best of luck to you for these elections. And today's subject, stillbirth, is very interesting. And at the end of the day, it would be very informative to all the friends, colleagues, and faculties and the audience. Thank you very much.
Thank you, Sudhir bhai, for sparing time and for your good wishes.
Thank you. Thank you.
You are always with us. You are also very person to encourage us in any of our activities. Thank you, sir.
Thank you.
Thank you, sir, for
Sudhir
your
sir.
blessing.
Yes.
Now we move on to our second session, first academic session, and I request Dr. Deepika to introduce the chairperson for the for the session.
We conclude the inauguration is over, and we thank PK Shah sir, Neeraj sir, and Sudhir sir for joining and gracing the occasion and blessing this webinar. Dr. Deepika, can I invite you to conduct the session next?
Yes. So thank you, Dr. Patel sir and Dr. Monica for giving me this opportunity. So we will straight away start with the first scientific session. And I have the honor to introduce our chairpersons for the session. Dr. Monica, are they? I cannot see them here. So should I go on to introduce? Is Dr. Jignesh Modi, has he logged in? He's our...
The Taravia is there.
Okay, Dr. Deepal Bhalodia.
You introduce and welcome them even in absence also, no issue.
All right, sir. All right. So I have the honor of introducing and welcoming Dr. Jignesh Modi, sir. Sir is the Secretary of Porbandar Obs and Gynae Society, and he's a senior consultant OBGYN at Riddhi Hospital at Porbandar. Our second chairperson is Dr. Deepal Bhalodia. Madam is the Secretary of Jamnagar OBGYN Society. She is working as an infertility specialist at Bhavishi Fertility Clinic, Ahmedabad. and has previously worked as a senior gynecologist at various tertiary care specialty hospitals in Jamnagar. Our next chairperson is Dr. Dhiren Taravia. Sir is a senior obstetrician gynecologist at Pooja Maternity and Surgical Hospital, Rajkot. Sir is the past president of the Rajkot Obs and Gynae Society, and under his leadership, hello, yeah, under his Rajkot Obs and Gynae Society won the Best Society Award at SOGOG 2022. Currently, sir is the Vice President of Rajkot Menopause Society. So can I request Dr. Dhiren sir to please introduce our speaker, first speaker for the session, Dr. Neeta Sata ma'am, who will be speaking on etiology of stillbirth. Sir is there? Sir, Dr. Dhiren is there?
Yeah, he is there.
Yes, sir. Sir, please can you introduce our speaker, sir? Dr. MC sir, should I introduce Dr. Neeta ma'am? Sir, should I go ahead and introduce our speaker? Dr. Dhiren, are you there?
Dr. Dhiren?
No, he is in OPD, I think, or something talking.
No issue. So
okay,
you can.
I will introduce Dr. Neeta ma'am, who was our speaker for the first session. Dr. Neeta ma'am is a consultant gynecologist and infertility care specialist at Shri Dwarkadhish Hospital and Kandor IVF Center at Jamnagar. Ma'am is the professor and head of unit at Shri MP Shah Medical College, Jamnagar. Ma'am is the former president of Jamnagar Obs and Gynae Society and was the organizing secretary of SOGOG 2019 Jamnagar. Ma'am is the recipient of many awards and author of many books and especially of the Best Innovative Laparoscopic Surgery Technique Award given by IAGE in 2008 and Gynae Excellence Award 2020. Ma'am will be speaking on the important topic of etiology of stillbirth. Ma'am, we welcome you. Please, could you start your presentation?
Yeah, thank you, Dr. Deepika. It's an honor to be a part of this webinar series. First of all, I would like to congratulate Dr. MC Patel, sir. I do believe that education is the most powerful weapon which can be used to change the world. And I would definitely congratulate Dr. MC Patel to have this marathon of education academic series, which is actually enlightening the knowledge among all the obstetricians. It being an OPD, I would straightly go with the topic, that is etiology of stillbirth. We all know that stillbirth is the most traumatic event which can occur, which can occur to any of the parents, and it is similarly traumatic to an obstetrician as well. It leads to significant amount of emotional distress, including grief, guilt, and even anger, to a patient as well as the obstetrician who is delivering the baby. So even lot many times it leads to isolation for the parents, and generally a comprehensive emotional, social, physical care and a spiritual self-care is required to heal these bruises. So let us go ahead with the topic, etiology of stillbirth. World Health Organization defines stillbirth as a death or lack of any sign of life among the product of conception, irrespective of the duration of pregnancy, before the complete expulsion or extraction from the mother. There are many different definitions which are being given by ACOG and WHO and other authorities. Like we would be going with a WHO definition that is like death of a fetus after 28 weeks of pregnancy before the delivery. Okay.
Ma'am, could I request you to please make it full screen?
Yeah,
मैम
sure.
फुल स्क्रीन नहीं आ रहा मैम थैंक यू सो मच
Okay.
नहीं मैम अभी भी नहीं आ रहा अब आ गया यस मैम
Yeah, yeah.
थैंक यू
Yeah.
थैंक
Okay.
यू सो मच
Yeah. It has a global impact. About 1.9 million of stillbirth occur annually worldwide, and India is recorded about 24.7 per thousand birth of stillbirth at 20 weeks, while 17.4 stillbirths per thousand births at 28 weeks of gestation on period. So, like as the gestational age advances, the rate of stillbirth changes. Now, considering the clinical imperative, accurate etiological determination is very much important. It is paramount importance for counseling, assessing the recurrences, and guiding the future pregnancy and management strategies to prevent emotional shutdown to the parents. It is very much required. See, when there occurs stillbirth, it is very difficult to answer the patients why it occurs. So, knowing the etiology is going to help you to counsel the patients and to take preventive measures for future pregnancy. Still, with many advances in obstetric care, stillbirth has still remained unexplained even in 76% of cases, and 76% of cases lack definitive cause. So, accurate identification of the cause of the stillbirth is very, very important. For which, like why the stillbirth remains still unexplained, it is because of the inconsistent classification system, varying investigation protocols, diagnostic uncertainty, declining autopsy acceptance by parents, and declining tissue preservation strategies. So it is very much important to counsel the patient of stillbirth to go for an autopsy and tissue preservation. And to get a better result, it is required that a multidisciplinary framework should be formed with detailed history, advanced imaging studies, comprehensive autopsy, placental pathology, molecular genetic testing, and micro CT or MRI usage, particularly when autopsy is declined emotionally by the parents. We all know that stillbirth has a complex multifactorial etiology with more than one factor contributing and leading to stillbirth. The commonest factor which lead to stillbirth are metabolic factors, placental and cord abnormalities, pregnancy-related other conditions, fetal factors, polyhydramnios and oligoamnios, infections and autoimmune causes. I have purposefully not included the intrapartum fetal death because it is all in all a separate topic to discuss for. Now, considering the maternal factors, diabetes is one of the commonest cause which leads to stillbirth. Type 1 diabetes has about 6 times increased risk of stillbirth, and type 2 diabetes has about 3 times increased risk of stillbirth, and even gestational diabetes has 1.5 times increased risk of stillbirth. So it is very much important to evaluate the like blood sugar level and to implement the strategy for regular timely 75-gram OGTT test among the patient, which should be done regularly for all the patients. Then hypertension is also one of the very common cause of stillbirth, leading to even preterm birth, which leads to stillbirth. Obesity, a patient with obesity with BMI more than 30 has about 2 times higher incidence of stillbirth compared to non-obese human. And even substance abuse, of course, it is not that common among Indian like Western countries, but definitely a use of alcohol and other substances addiction leads to increased incidence of stillbirth. Now, the commonest factors, which are placental and cord abnormalities, the compromised uteroplacental circulation leads to about 3 times increased incidence of stillbirth, placental abruption, velamentous insertion, and vasa previa leads to stillbirth. And very important is cord entrapment, cord prolapse, cord obstruction, cord knot, thrombosis and stricture. So Doppler studies in third trimester and in-time evaluation of compromised uteroplacental circulation and to early diagnosis of cord knots are very important strategies to prevent stillbirth. Considering the previous adverse pregnancy outcome, when there is history of previous stillbirth, it is very much important to finalize or to plan the strategies in the next pregnancy. The way I have said that you have to form a framework which includes diagnostic accuracy, a detailed history, what was the cause of stillbirth, whether the tissue preservation was done or not. We have to go for a genetic tree makeup of the patient and her husband to find out any genetic causes, and increased incidence of stillbirth among the patient with previous stillbirth is about 3 times. Preterm birth definitely is one of the very common cause of stillbirth, and definitely SG and IUGR, as I have discussed earlier. Now, considering the fetal factors, congenital malformations, especially the structural malformation. Generally, see, it happens that when we find any isolated malformation with all the other factors normal, it is not being taken seriously. But let me inform that isolated cleft lip even has increased incidence of stillbirth, that is about 10 to 15 per 1,000 births. Even isolated spina bifida has about 24 per 1,000 birth incidence of stillbirth, and transverse leaf deficiency has increased incidence up to 26 per 1,000 births. About 20% of the structural malformation, stillborn patients have a dysmorphism. And very important is amniotic band syndrome with limb defect. It has very high incidence of stillbirth, as high as 110 per 1,000 births. Now, considering the chromosomal copy number variations, particularly duplication and deletions. See, about duplication of 21q 22.13 leads to cardiac defects, while deletion of 1q 21.1 leads to skeletal defects. So it is very much required that when we are investigating a case of stillbirth, it is required that from the tissue microarray should be advised to all the patients. Now, considering the polyhydramnios and oligohydramnios as one of the very important cause of stillbirth, even among the idiopathic polyhydramnios patients, about 1.5 time incidence of stillbirth is being observed rather than a normal patient with a normal amount of liquor. Polyhydramnios with fetal or maternal conditions has 13.4% increased incidence of stillbirth, and the risk of aneuploidy is also very higher, up to 3.2%. Generally, it is being observed about 1 among the 1,000 birth. The structural malformation of CNS, gastrointestinal and cardiac defects are also about 2 times more among the patients with polyhydramnios. The risk increases as the gestational age advances. So, there is 11 times increased risk of stillbirth among the polyhydramnios patients who have reached 40 weeks. So it is very important that evaluate the patient at 37 weeks, confirm the maturity, and deliver them before 40 weeks. Because at 40 weeks, the risk increases about 11 times. And now, considering oligohydramnios is one of the very important cause of stillbirth, especially oligohydramnios is associated with many structural defects and even increased placental insufficiency. Both contributes significantly to incidence of stillbirth. Another very important cause which nowadays we are alert about is infection and autoimmune disease. Infection should be considered or stamped as a cause of stillbirth only and only when it is detected on placental autopsy culture. Directly to jump with the cause, infection as a cause of stillbirth is a myth, basically. So we have to investigate thoroughly and then prove that this infection was the cause of stillbirth. The incidence of infection before 28 weeks is 19%. Before stillbirth before 28 weeks is 19%, while it is 2% at term. The commonest bacterial infection which is found among the stillbirth patient is E. coli, beta-2 streptococci, and among the viral infection is CMV, HSV, and parvovirus infection. Even malarial infestation leads to about, particularly in third trimester, leads to about 2 times increased risk of stillbirth. So it is very alarming incidence, and we need to be very careful about this. Generally, it happens that patient with fever and either is being referred to a physician and she comes back. We do not know what was diagnosed. So it is very important that try to know the reason for the fever in third trimester and treat accordingly. Now, autoimmune disease, sort of an EPLA syndrome. It is very important to stamp EPLA syndrome only and only when we meet with one clinical and one lab criteria. Particularly, the lab criteria should be like repeated 2 times at a 12 weeks interval, and ACALA 92 beta glycoprotein above 99th percentile should be there to stamp the patient as a case of EPLA syndrome. The stillbirth risk among the EPLA syndrome positive patient is highest when all 3 lab criteria are positive, while lowest when LA is negative. SLE, celiac disease, rheumatoid arthritis, and RBS like autoimmune diseases also leads to increased incidence of stillbirth. So all in all, when we want to reduce this trauma to the patients and to ourselves, a holistic classification system, which includes contemporary framework, integrating all clinical data, imaging finding and pathological research, and molecular genetic advance usage of molecular genetic sequencing techniques to be incorporated among the clinical practice to reach to a particular diagnosis and a cause of stillbirth, and then to treat the patient. Thank you.
Dr. Deepika? Thank you, Dr. Neeta. That was an excellent deliberation on the antenatal aspects of stillbirth. And all of us know that stillbirth is an obstetrician's I think one of the most dreadful feelings we have when somebody comes up with a stillbirth and we don't know the cause of the same. So thanks a lot for deliberating on that and giving us all the details about the same.
Thank you,
Moving
Dr.
on to thank you. Moving on to the second session, we have eminent chairpersons in this session, and Professor Hinaben Patel, the President Jamnagar Society. She has, with a teaching experience of 35 years and interest in high-risk pregnancy, uterovaginal prolapse, a BMOC trainer, RCH trainer, expert at UPSC. She's an ideal for being a chairperson in this session. Unfortunately, she can't attend today because of personal problems. However, she sends her best wishes. The next chairperson is Dr. Anand, Dr. Devraj Dibhadarka, and he's an IVF specialist. He is the secretary Junagadh Society, and with advanced training in ultrasounds. So he would be something great. Would be a great chairperson for this intranatal fetal monitoring session. With insights from him would be very effective. The third chairperson for this session is Dr. Anand Bhagde, and he is the secretary Jamnagar Society. Is any one of the chairpersons there? Because I can't see the names in the participants group. Any of the chairpersons there, please? If not, the eminent speaker for today's session is Dr. Karthik Suresh Murjaria. And Dr. Karthik, if you see his CV, he has got a FOXI approved advanced ultrasound training under Dr. Janak Desai, Ahmedabad in 2013. But what was really very interesting was an observership in Harris Birthright Institute, King College London, under Professor Kypros Nicolaides. And Professor Kypros Nicolaides, ladies and gentlemen, is the father of fetal medicine. Then he has a fellow in he's a fellow in advanced obstetrics and gynecological ultrasounds. He has a number of publications and awards, and he's also been the winner of the Rocks Young Scientist Award in 2024. So he has got immense training, immense knowledge in ultrasound, and he is, I think, the perfect person to be dealing with the very complicated topic of intrapartum fetal surveillance. Dr. Karthik Suresh, please.
Yes. Shall I share my screen? Thank you for the kind words. Okay, is the screen visible?
Absolutely. Please make it. Please make it.
Yes, sir.
Okay. So first of all, thank you, Dr. MC Patel sir, for inviting me for this talk. And I have a humble appeal to each and every Foxian who is participating. Please vote on the first day itself. Your voting is very important. And please vote for our Honorable Dr. MC Patel sir. Now, which are the methods which are used for surveillance? So some methods are commonly used, which is intermittent auscultation, continuous cardiotocography, and ultrasound is still upcoming, actually. That is a surprise. And very rarely used or of theoretical importance, fetal scalp stimulation test, fetal scalp pH, fetal pulse oximetry, and fetal blood sampling. Okay, so this was a landmark paper published in the year 2013, and classification and diagnosis of fetal growth restriction. So this chart is from that paper. As you can see that there is some correlation between Doppler changes and hypoxia and acidosis. So in stage 3, as we can see, there is a low suspicion fetal acidosis, and it is associated with reversal of flow in the umbilical artery. And stage 4 is high suspicion fetal acidosis, and it is associated with DV reversal. Okay. And the computerized cardiotocography shows less than 3 milliseconds variability. So the CCTG changes are seen later than what things are seen in ultrasound. So ultrasound changes precede acidosis in fetal growth restriction. So with
Dr. Karthik, we can't hear you.
Yeah, actually, my screen just went off. So
No, we can see your screen.
Okay.
You've written with Dopplers, we can suspect acidosis.
Yeah. Now with Dopplers, we can suspect acidosis and hypoxia, and hence fetal scalp pH, fetal blood sampling, fetal pulse oximetry are nowadays not commonly used. Now, what is fetal scalp stimulation test? If we stimulate the fetal scalp with the pervaginal examination with membranes need to be ruptured for that, then there is an acceleration noted in the CTG. But all these tests are now not used. Now I'll go to the cases. Mrs. RJ, 35 years, 35 weeks. She had a previous one cesarean, previous one ND, one female child 10 years alive and healthy. Then she had a fetal death at 8 months, intrauterine fetal death at 8 months, or what we define as a stillbirth. At present, NT scan and anomaly scans were normal. She came to me for urgent ultrasound in view of abnormal Doppler findings. So this is our amniotic fluid index. It is 1.5, so severe oligo. And on scan, I could see that there is pericardial effusion. Okay, so this is fetal chest, heart, and adjacent to it, there is a fluid collection, which is pericardial effusion. And there is presence of ascites. Okay, and the Doppler changes, there is a absence of flow in the umbilical artery. And as you can see in this on the right of the screen, that the ductus venosus shows abnormality. So there were abnormal Dopplers and there was a failing heart. It was a failing heart with abnormal DV, stage 3 Doppler changes, suggestive of early acidosis. That patient was advised urgent delivery, reached the consultant after 2 hours, and unfortunately, the baby could not be survived. So case number 2, 28 weeks, one full-term normal delivery, alive and healthy. She came for a second opinion for fetal echo at 28 weeks. She had a complaint of pain in abdomen for past 3 days. As you can see that she is having gross polyhydramnios. The amniotic fluid index is 35. The stomach was visualized. And on transvaginal scan, I could not visualize the cervix. The cervix had entirely opened up. So there was gross poly, explained high risk for tracheoesophageal abnormalities. As cervix could not be visualized, counseled for urgent referral back to consultant. Preterm delivery was predicted and she delivered after 2 days at 20. But the fetus could not be survived because of gross prematurity. Now, the third case, 29 years, previous CS, 38 weeks, referred for Doppler assessment. So when I did a TVS, the placenta was completely, this is the cervix and this is the placenta, lower edge of the placenta is covering the os. She's a previous CS, placenta is anterior and low. In this case, we can see that the placenta should be absolutely homogeneous. But here we can see there is some black structures. So that is a heterogeneously appearing placenta called the moth-eaten appearance. On color Doppler, it turned out to be a placental lacunae containing a lot of vascularity. She was reported as a placenta excreta spectrum and the planned obstetric hysterectomy was done for her. So with these cases, it is clear beyond doubt that ultrasound is a very handy and accurate tool for assessment of fetal environment, like fetal amniotic fluid, fetal placenta, and the general fetal well-being, whether the fetus is having any gross hydrops or not. And it is an excellent value addition in our intrapartum fetal surveillance. Okay. Now, what do the NICE guidelines say? So the NICE guidelines recommend intermittent auscultation. Why this when continuous CTG is available? Because there is evidence that in low risk population, if there is an increased risk of unnecessary interventions with continuous CTG. So in low risk, stick to intermittent auscultation. How to do it? It can be done with a stethoscope or a handheld Doppler. In the first stage, every 15 minutes, we have to auscultate for full 1 minute, no multiplication, 15 seconds into 4, no. And second stage, every 5 minutes for full 1 minute and after every contraction. We should try to note the presence of any accelerations or decelerations. What are the indications of continuous CTG? Antepartum complications, as ma'am said, all the risk factors for stillbirth, we have to go for continuous CTG, like previous CS or full thickness scar, hypertensive disorders of pregnancy, PROM, bleeding PV, other than show, suspected sepsis or chorioamnionitis, pre-existing or gestational diabetes, fetal growth restriction or small for gestational age fetus, non-cephalic presentation, post-term pregnancy, and oligo or poly. Or if there are any intrapartum complications like contractions lasting for more than 2 minutes, usually less than or for up to 45 seconds, meconium stain like a pyrexia or induction by oxytocin. So in these conditions, we should go for CTG monitoring. Now, what are the components of that? Baseline heart rate, mean heart rate excluding accelerations and decelerations should be measured. The normal is between 110 to 160 per minute. So this is a CTG trace. It should be accompanied by a tocodynamometer. So the bottom graph shows the number of contractions and the upper is the tracing of the fetal heart rate. As we can see, the fetal heart rate is not steady. It is going up and down. So that is what we call as variability, and the mean should be the baseline heart rate. It is around 120 here, so the baseline heart rate is 120. What is variability? Minor oscillations in the fetal heart rate measurement. It determines variability. We have to determine variability by noting the difference between the highest and the lowest rate during 1 minute cycle. What is the normal range? Between 5 and 25. Variability is normal. So as we can see, again, the upper graph is the fetal heart rate, lower is the tocodynamometer showing the uterine contractions. So we can see is marked in these red arrows that the variability of 20 is here, again 20 and 10. Okay, so it is 10 to 25 is the normal beat to beat variability. So this is an example of reduced variability. We can say less than 5 variability is there. So it is a reduced variability. Visually also we can see if we don't want to measure. So now the third component after baseline and variability is the deceleration. What is deceleration? It's a transient decrease. It's a transient decrease of more than 15 beats per minute and lasting for more than 15 seconds. Minimum 15 seconds. Decelerations can be of 3 types. First type is early. It starts at the beginning of the uterine contraction and ends with the uterine contraction. It is usually due to head compression and benign finding. So here, again in this graph, the uterine contraction has begun. The deceleration has also begun. Uterine contraction progresses and ends here. The deceleration also ends, and again it joins the baseline. So it is an early deceleration, begins with and ends with the contraction. It is a benign finding. The second is variable deceleration. It occurs irrespective of uterine contraction. There is no relation between uterine contraction and this type of deceleration. It is due to cord compression. The concerning characteristics are if it lasts more than 60 seconds or there is a reduced baseline variability during the deceleration or it fails to reach the baseline, then it is concerning. Otherwise, it is not of much concern, usually due to cord compression. Again, the graph, this is the contraction, but the deceleration is during the time of relaxation. So there is no relation between the uterine contraction and the deceleration. The third is, this is the sinusoidal pattern. So this type of deceleration is not considered normal. It is again an alarming sign. What is late deceleration, which is a very great alarming sign? Due to decrease in uteroplacental flow, the late deceleration starts at the end of uterine contraction and ends after the contraction is over. Okay, so this again is the uterine contraction. And here is the beginning. See, in the end part of the uterine contraction, it starts, it goes down, again goes up, and the deceleration goes back to the baseline after the contraction is over. So this is an ominous sign. Late deceleration is not considered to be normal. What is an acceleration? Acceleration is a very reassuring sign. There is a transient increase of more than 15 beats for at least 15 seconds is considered to be an acceleration. Okay, so here is the acceleration. There is an increase in the basal heart rate, and again it goes down. There is an increase, it goes down. So the CTG trace is very reassuring. Now, what are the normal CTG findings? Reassuring baseline, as I told you, between 110 to 160. Baseline variability between 5 to 25. None or early decelerations and variable decelerations with no concerning characteristics for less than 90 minutes. Okay. So now this non-reassuring features are those which are not reassuring are non-reassuring. So these are all major theory, but I want to focus more on ultrasound. So I will take that first. Ultrasound in labor. So this is not given by NICE guidelines, but ISUOG, in International Society of Ultrasound in Obs and Gynec, has introduced this. What are the indications as of now? It is not to replace the clinical judgment, but it is supposed to be used as an adjunct to it. So what are the indications? Slow progress or arrest of labor in the first or second stage. Slow progress or arrest. Or before any operational vaginal delivery. And if we want objective assessment of fetal malpresentation, then this is to be done. So these are the ISUOG guidelines which were updated in 2018. Even our PNDT, there is one in that indications observation of intrapartum ultrasound is there. So we can use it. Equipment, machine should be quick to start. They have specifically said this. If the machine takes 10 minutes to start, then and a lot of events would have taken place. And basic convex ultrasound 2D probe is needed. No fancy stuff is needed for this. So ultrasound, I told you, we want to check the fetal environment. We want to check the fetal biometry, weight, the well-being, Dopplers, cervical assessment, and placenta. Correct? But now this is for the progress of labor. That is compulsory, but this is as an adjunct to clinical findings. Ultrasound is yet not used in active labor very commonly, but studies have shown that it is more precise and reproducible than clinical examination. They did simulator studies. They asked the residents and the consultants in US to do a simulator study and check the station of the fetus and the head position. It is to be noted that there was a 30% error rate. Nearly 1 in 3 was wrong. The station told by the clinical examination, the actual station, 1 in 3, it was wrong. 30% error. Ultrasound allows objective measurement with precise documentation. It is very useful for fetal position and fetal station assessment. As of now, it is useful for cephalic. For non-cephalic, it is not useful. It is recommended to be used as an adjunct. So we will use how it is used for noting the head position. We have to do a transabdominal ultrasound, as we all are doing. Trace the fetal spine. We have to trace the fetal spine, go to the suprapubic region. Okay, go to the suprapubic region and visualize the fetal head. Orbits, if we see, then the fetal position is occipito-posterior. If we see the spine, then the fetal or the occiput, then it is occipito-anterior, and the cerebral hemispheres are occipito-transverse position. As we can see in this image, this is the maternal abdomen. The fetus is lying down like this. It is in the occipito-anterior position. In the ultrasound, we can see the occiput and the cervical spine. In this second image below, we can see that the baby is lying down in occipito-anterior position. Our probe is in the suprapubic region. We can see on ultrasound that there are fetal orbits. Okay, so it is an occipito-posterior position. So it is as simple as that. No great learning curve is required. You just have to trace with the help of transabdominal ultrasound. Then for the fetal head station, there are many markers, but the common two used is angle of progression and head perineum distance. These two are commonly used because there is a linear correlation between these two and the fetal station. So what is head perineum distance? First, I'll go to this image. As we can see that we have to place the ultrasound probe in a transverse direction, transversely, near the posterior end of the perineum. Correct? Then in this image, this is the perineum transducer. The uppermost line, as we see, is the perineum transducer. And this is the fetal head. So we have to measure the distance between the perineal transducer and the fetal occiput or the fetal bone. This is the skin. Skin should not be included. The skull or the fetal bone should be measured. This distance is the head perineum distance. You just prove the probe, apply slight pressure, and then measure this distance. This is head perineum distance. Okay. So HBD is straightforward to measure and reproducible. Transducer is placed transversely, transperineally, and between labia majora, and the soft tissue compresses against the pubic bone. HPD corresponds to the path of birth canal to be passed by the fetus. Shortest distance from the outer bony limit of fetal skull perineum. And what corresponds to station 0? The distance between, say, approximate 35 to 38 mm corresponds to station 0. So if the distance is 36 mm, we can say that the fetal head is at the station 0, just by putting the probe and measuring the distance. Okay, so that is the head perineum distance. Then the other measurement is the angle of progression. Okay, again, I'll go to the image first. In this, as we can see, we have to place the probe longitudinally. Place the probe longitudinally. What structures we will see? we will see this. This is the symphysis pubis. So in the corresponding ultrasound image, this is the symphysis pubis. And the second structure to be demonstrated is the anterior and the posterior tables of the skull. So again, here we are seeing the anterior and the posterior tables of the skull. This is the anterior table. So how to measure this angle? Draw a line through the long axis of the symphysis pubis. Once it ends, again draw another line from the lower end of it, through this lower end of it, and as a tangent to the deepest part of the fetal skull. So draw two lines. Once again, I'll repeat, through the symphysis pubis, and the second line should be as a tangent to the deepest part of the fetal skull. What you have to do, you just have to place the probe longitudinally in the midline. Okay. So it is measured transperineally, probe longitudinal in the mid-sag plane. We can see the pubic symphysis and the anterior and posterior parts of the skull. So angle is drawn by joining a line through the long axis of the pubic bone and tangent on the inferior margin of the pubic bone and deepest bony part of the fetal head. Okay. So what is important, as you can see, what are we measuring? The angle of progression is 116, then it corresponds to station of 0. It is 127, then station of 1. It is 138, then station of 2. So as the angle increases, we can easily document the fetal head station. So it is very accurate, and there is no great learning curve. You just have to do 5 times, it will be, you'll get the hack of it. So ultrasound is a quintessential tool for accurate assessment of fetal well-being, fetal environment. I strongly recommend using it on admission. As I already mentioned, the changes precede the cardiotocography. Fetal position and fetal station assessment can be accurately assessed by use of intrapartum ultrasound, and learning curve is short. Thank you. Thank you for the kind invitation.
And do we have any of the chairpersons right now? I think it was a wonderful talk. Just from the antenatal aspect, when would you consider delivery of the baby at absent end diastolic flow of the umbilical artery or reversed end diastolic flow of the umbilical artery? Or would you just rely on the CPR?
No, actually, see, in this chart, again, it is very, can I use the chart again, ma'am?
Sure.
Yeah, so see, it depends. There is in this paper, see, if we need to reach a particular gestational age, suppose umbilical absent end diastolic flow is there, and if the fetus is already 34 weeks, then deliver. If it is less than 34 weeks, then we need to monitor bi-weekly. Our aim for prenatal is we need to avoid acidosis. There is a fine balance between prematurity and neonatal risk. So this paper gives a wonderful correlation. In this stage 2 severe placental insufficiency, there is an umbilical artery absent end diastolic flow. So deliver what gestational age we want to reach, 34 weeks. Suppose if there is maternal preeclampsia, then we can, we don't need to, if there is maternal preeclampsia, then we need to take that into consideration also. But if otherwise the mother is fine, then we need to pull on till 34 weeks with a bi-weekly monitoring. And suppose the fetus is only 30 weeks less or 29 weeks and reversal is there, then we need to ensure that it reaches 30 weeks. So it depends on the gestational age, and if it is more than 34 weeks and absent flow, please deliver.
Thank you. Thank you. Because my
Dr.
boss is
Karthik,
always...
one question from my side also.
Yes.
Have you got an experience of seeing the progress of labor through the ultrasound?
I don't do deliveries actually.
No. Have
Yes,
you
but we can
do. That
Huh.
was a very good idea from yours, because it will be very easy for for us to explain to the patient that the head is not descending, and that's why we are going to go for a cesarean section, and it will
Yes.
be a very good tool for the gynecologist or obstetrician who are going to deliver. But have you any of the person from India has done a trial on it?
Not trial, not yet, but see, one of our colleagues, they had presented, they had tried. I mean, so it was very handy. She said it was very handy to note what is the fetal station and all. She could easily
Because I
coordinate.
was also seeing because whenever you are doing, you can do a basic ultrasound by yourselves also.
Yes.
And
So both these measurements are so simple that you can do it. Everyone
Do
now
it
has
yourself.
an ultrasound machine.
Yes.
So it is very simple. I mean,
So I think in the future days, this
it
will
will be
become a very
compulsory.
good tool.
Might be the obstetricians will forget to use their fingers and only use ultrasound.
Use the ultrasound.
But as of now, they recommend to be used as an adjunct only. So clinical
Thank you.
first and then ultrasound. Yes.
Thanks a
Should
lot.
we proceed
Yeah,
to
we
the
progress.
next session?
Absolutely,
Yes, yes,
absolutely.
yes. I'll stop.
Absolutely.
Thank you. Thank you for invitation.
Thank you. Now I
Thank
hand
you,
over
Karthik sir,
to
and
the
thank you,
next
Chairperson.
coordinator.
Yeah. Can we move ahead with the next session, which is by none other than Dr. MC Patel, sir. Our chairpersons for today, Dr. Gopal Hirani, sir, Dr. Kuntal Jadeja, and Dr. Puneet Khatri. Can we have the CV slides, please? Dr. Gopal Hirani, sir, is a private practitioner since 1985. He has been the chairperson of the SOGOG in 2004, and he's currently the professor in OBGYN at GAIMS. We welcome you, sir. The next slide, please. Dr. Kuntal Madam is currently working in Rajkot since 2009. She is a full-time fetal medicine consultant at Narayani Hospital, and she's conducted various one-day CME courses for obstetricians at the Narayani Hospital. Our next chairperson, Dr. Puneet, sir. Can we have the slide, please? Team Corona. Dr. Puneet Khatri, sir, has passed his MBBS in 96, and he has delivered a presentation in various state and national conferences. He's also presented a paper on high dose of calcium in preeclampsia and FIGO in 2012 at Rome. And I now request all our chairpersons to please introduce Dr. MC Patel, sir. Team Corona, can we have the CV slide, please? Gopal sir is there. Could you please share Dr. Patel sir's slide? Yeah. Can I request Gopal sir to please introduce, sir?
Thank you very much. Dr. MC Patel sir have a very about webinars and 207 webinars. So he is so much deeply academically involved, and as you know, there's I think he devoted his whole life, the afterlife is in the academic session, and he is now contesting for the president 2026. I hope he should win this presidency. So, sir is very deeply knowledgeable in medical legal cases, and I so often I take advice for these medical legal cases. Sir, and everybody knows that after stillbirth, when the stillbirth occurs, so we have a very great tragedy in our private practice. So what to give answer to the patients, and what are the reactions of the patients? Because nobody will accept any stillbirth or any mishaps in our hospitals. So at that time, if have a proper idea, proper understanding to the patient and discussion with the patient, and that will be help a lot. I hope Dr. MC Patel will more idea regarding the aftermath of the stillbirth. Sir, now you give more ideas on this.
Thank you, Dr. Gopal Hirani. Any comments from Kuntal Jadeja, opening remarks, or should I go to the subject? You are muted, Kuntal.
Yes, sir. Yes, good evening, sir. Yes,
evening.
eager to hear from you because as Sir Gopal sir said that IFD nobody will accept now. So after your guidance, we will be equipped. All gynecologists will be equipped to do all the necessary, and we feel confident that we have done enough. So eager to hear from you, sir.
Okay. Thank you, Kuntalva. Greetings from Statue of Unity, tallest statue of world, and we all are sorry, proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar, Bhuj, Jamnagar, Rajkot, Porbandar, and Junagadh, and President and Secretary of respective society. At the same time, I would like to thank you all to be with me, just like a rogue during my election campaign last year. Though I lost, but I believe in this. It was very nicely written by श्रद्धेय अटल बिहारी वाजपेयी, क्या हार में क्या जीत में, किंचित नहीं भयभीत में, कर्तव्य के पथ पर जो भी मिला, ये भी सही, वो भी सही. So loss is not the end, but new beginning, and journey to South Foxy continued with renewed patience. So thanks everybody for everything, and still my commitment is there. Wherever you are, I'll be there. Promise to reach the unreached, and I'll be seeking same blessing, same support, same guidance next year in 2026 for the same post, President Foxy election year 2026. And straightway coming to the subject, IUFD, aftermath and beyond. So usually I start any of my talk with this question. Is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as litigations are concerned, because we take utmost care of any of our patient in our obstetric care, either in labor room or in antenatal, but accident may happen at any time, and it becomes difficult for us to explain to the patient and patient party. As far as IUFD is concerned, it is a potential condition as far as litigations are concerned. Let us see, these are the real happen cases. This is real happen case in city of Ahmedabad only. Regular antenatal checkup, sonography every time, told everything fine to be normal, except polyhydramnios. At 34 weeks of pregnancy, on routine antenatal checkup, it was found a case to be IUFD. Advice CN section, preoperative investigations were done, and blood sugar came out to be 432, which was never done, which were never advised. This type of blunder cannot be excused, but 432 blood sugar, ultimately it led to IUFD. Case was filed, notice was served, and compensation demanded 1 crore. Still case is on. So let us see what will be the judgment. Let us see one more case. This is also a real happened case in the state of Gujarat only. Unbooked patient, primary 34 weeks of pregnancy with PIH, advised necessary investigation and treatment. It was very first visit with this gynecologist. Previously, patient was being taken care by some other gynecologist in other town, but it is customary tradition to get delivered in first pregnancy at maternal place. So she had been to her maternal place, and with this gynecologist, it was very first visit. So he advised all necessary investigation. He prescribed necessary treatment for PIH, etc. But unlucky that patient and that gynecologist too. Very next day, she developed abruptio and intrauterine fetal death. Cesarean was advised. Relative opted option to go for second opinion in nearby town. So they went to surgeon in nearby town. Cesarean section was done. Again, unlucky patient and unlucky that surgeon too. Patient developed atonic PPH, and in spite of all their efforts, they couldn't control bleeding, and ultimately hysterectomy was done. Can you imagine the situation? Primary patient, IUFD, and ended into hysterectomy. So notice was served, case was filed. Allegation to first gynecologist was not properly managed to prevent abruptio and IUFD. And allegation to second doctor, that is surgeon, not tried to prevent PPH, and atonic PPH was not managed properly. So this type of cases we may face in our day-to-day obstetric practice. Many a time this could be the conversation on part of patient or patient relative. You said everything was all right just 10 days back. Then why this occur? How, doctor? And it becomes very difficult for us to explain to the relative. It has great physical, emotional, psychological, and social trauma for parents and naturally for family too. So if we go with incidence, India is highest in number as far as stillbirth are concerned. So we should be very careful for that. And India contributes almost 22.6% of world stillbirth mentioned by Dr. Nita Sata madam also. So after this, our first step is confirm the diagnosis, because many times 50% of stillbirth are preceded by decreased fetal movement. Sometimes fetal movement perceived even after IUD, and fetal movement scan correlation has false positive rate up to 30%. Auscultation may be inaccurate. With inaudible fetal heart sound, baby may be viable. So gold standard is ultrasound, and it will reveal all the information related to placenta about location, retroplacental bleed, and as far as fetus part is concerned, presentation, approximate weight, Spalding sign, if it is old IUFD, high drops, and any gross anomalies to the fetus. So ultrasound is the gold standard as far as diagnosis of IUFD is concerned. So we have to confirm diagnosis, and we have to quickly go to clinical evaluation of the patient and exclude immediate severe maternal morbidity. Say, for example, if she is having acute abdominal pain, rule out abruptio. If she is bleeding vaginally, then we have to take care for that also. Labor symptoms, PPROM, obstetric emergency like eclampsia and maternal collapse. So our approach in this type of situation should be totally different. So evaluate probable cause of IUFD. Dr. Nita madam had rightly mentioned in her first talk, so I do not go into detail. But very quickly, if we go, etiology could be antepartum, intrapartum, and majority of the cases, almost 25% to 35% related to some placental pathology or related to some cord problem. But very important part in this situation is communication to the patient as well next of kin and to relevant authority also. So in this situation, most terrible thing, it happens to any obstetrician to declare bad news like this. And where do we go from here is very difficult one. But if you have rushed him in your society, in this type of situation at the time of declaring bad news, it is always better to call our professional colleague to be with us at the time of declaring bad news. But at the same time, members who have joined RUST team, they have also keep in mind that main chair belongs to the owner. So person who has dealt with the situation, he will the person to talk with the relative of the patient, and he will declare that bad news. Communication is his job, and your role is only to facilitate the condition if at all it is required. Do not take it as an opportunity to settle the score by giving subtle hints to relative that there was negligence, because many a time what happens, some senior person is there in that very team, and one of any relative is known to him or her. So he will say, can you remember some 10-15 years back you had been with some serious patient, and with all our hard work and try, we could save both mother and baby. So this type of loose comment many a time becomes troublesome to obstetrician who is facing this situation. So communication with relative is very much important. हम आपके बच्चे को बचा नहीं सके. It seems very casual in Hindi film or so, but in our practice we cannot simply say like this. Inform condition from time to time. Whenever you are dealing with any high risk pregnancy cases, then we have to inform condition time to time, because if at all it ends into IUFD or so, it becomes little easier for us to face the situation. If it is a case of GDM, we know sudden IUFD is known in GDM, severe preeclampsia, eclampsia, severe IUGR, abruptio. So if we are facing this type of situation, then we should be alert to deal with the situation and to talk with the patient and patient party time to time. And whenever we declare this, it should be by senior most person of the team, not by junior one. If in that very hospital more than one persons are working, then head of that team will declare this bad news to the relative. Face together with RUST team if available, just I mentioned. Be polite and sympathetic but assertive. Whenever you are declaring this bad news and explaining everything to the patient, then you should be, of course, polite, sympathetic, but you should be assertive too. Be prepared for knee.
તું કઈ હળી ન કરતો મારે અહીંયા
Be prepared for knee-jerk hostile reaction or be prepared for mob frenzy, because we do not know what could be the reaction on part of a patient or relative in this type of situation. Do not lose patience, because there are so many questions bombarded from patient or patient party. Many times same questions are asked by different relative, and many a time we may lose patience and scenario may be different. So do not lose patience, and we have to answer all the questions raised on part of patient or patient party. Do not blame each other. This is also a very important part. When more than one person is involved in treatment, then do not blame each other in presence of patient or patient's relative. As far as breaking of bad news is concerned, use a private room, arrange interpreter if necessary. If patient is not well versed with language, then you can use interpreter also. But remember, in this situation, never allow family member as an interpreter, because we never know what she explained to the patient and patient party, what we have explained. Discuss care and decision with both parents and or a support person, and document plan of treatment. So further plan of treatment we have to discuss with patient and relative also. Nurse, registrar, other members of multidisciplinary team should be available to give parents further information on diagnosis. Sorry, what happened? Sorry, some technical issue. So just I mentioned, nurse, registrar, other members of multidisciplinary team, they should be available to the patient and patient party. But here, word of caution: before they are available to patient or patient party, we should have word in between that exactly what happened, what we have done, and what is the line of treatment further. So each and every member of your staff should speak in a same language, same direction, because there should not be contradiction in their talk to the relative of the patient. As far as management plan is concerned, either we have to deliver and we have to go for some investigations. Also, clearly document in a chart in consultation with parents about your management plan further. Management may be expected or involve medical induction of labor. It depends upon the condition of the patient. Urgent delivery is needed in case of abruptio, APH, preeclampsia, eclampsia, sepsis, PROM. So in this type of situation, we have to go for either induction or any other measures to deliver the baby. So in this situation also, we have to explain everything to the relative of the patient. But as far as this expectant treatment is concerned, more than 90% women go into labor within 3 weeks of IUFD. But in this, disadvantage is 10% go in DIC in 4 weeks, 30% go in DIC after 4 weeks. So we should be very careful if we are giving expectant treatment with all due investigation. May have difficulty in identifying the sex, because whenever we deliver after a few days, then baby will be totally macerated one. So value of post-mortem examination decreases with this, and delay for 48 hours do not add any risk if no other associated complications like sepsis, preeclampsia, abruptio, or membrane rupture. So you can wait if this type of comorbidities are not there for 48 hours or so. But if it is delayed more than 48 hours, then we should arrange twice weekly for full blood picture and coagulation profile, and we should be ready to deal with the situation accordingly. Offer choice of induction if indications for induction are present, and we have to explain everything to the patient. If alternative mode of delivery we are going to consider, then document the region. Say for example, immediate cesarean section we are planning, then we have to mention what is the indication of that very cesarean section, and proper counseling very quickly and proper consent is to be taken. As far as care in labor is concerned, in this type of patient where it is already IUFD, preferably in a private room, that very patient should be given. Display hospital pregnancy loss symbol on door of room. So decorum of that room should be maintained. Allocate one nurse to that very family for intrapartum care. Prepare parents for appearance of baby after birth. They should be mentally prepared to face the situation in this. Discuss about parents seeing and holding the baby after birth. Check that full blood count, group, coagulation profile have been done in last 24 hours. Many times it is request on part of anesthetist if at all we are going to go for operative delivery. Use partogram during labor. It shows your consent to take care of your patient. Care of stillborn baby, it is also very much important part. Get verbal consent for initial examination with the patient and relative. Offer parents opportunity to dress and hold the baby. Many a time relative are interested to dress the baby and hold the baby and have photographs also. Assist parents in taking photographs, just I mentioned. Send cord blood if patient is RH negative. General appearance of placenta, weight, cord, membrane, any retroplacental clot, everything should be mentioned in our document. Number of vessels, any notes, true note or false note, cord around neck, tight or loose. We have to mention everything in our record. Sample of placenta and or cord for cytogenic testing is to be taken before we put placenta in formalin, if there is a protocol in institute where we work. Placental swab obtained from both sides, fetal and maternal surfaces, for further cytological investigation. Placenta sent to histology with appropriate request form is also part. As far as all these mementos are concerned, so we have to help a patient's relative if they are interested to have hand and footprints, lock of hair, name band, cord clamp, memory box, photographs, whole body X-ray infantogram or ultrasound scan. So if they are interested, then we have to assist them to get all this to them. As far as fetal autopsy is concerned, this is also a very important step to know exact cause of IUFD. But it is a very personal decision on part of patient and patient party. So consent should be there from patient and patient party to go for autopsy. It helps in diagnosis and cause of death or add information in 20 to 76% of the cases, but may change final diagnosis or affect genetic counseling. And in clinically unexplained stillbirth, relevant condition at death classification should be recommended. If parents decline autopsy, many a time patients and relatives are not ready to go for autopsy. So in this situation, you can request them examination of baby by neonatologist, by pediatrician, or by pathologist as far as external examination is concerned. But again, for this also, we will have to obtain consent, and we have to obtain consent for clinical photographs also. If at all we are interested to take photographs of baby, consent from patient and patient party is very much must. One more area, please do not forget, the bereaved parents need a lots of support. Each person is different and will go through their own grief, because different person at different level of acceptance in this type of situation. You can't do anything to make it better, but you can be present all the time with them to be with them. As far as documentation is concerned, naturally these are the potential cases as far as litigation is concerned. So your documentation, your record keeping should be very much up to date. Whatever happened, whatever you did, it should be mentioned in that very paper. So all the OPD case paper, indoor case paper, whether your patient is booked, unbooked, or it is an emergency patient, you have to maintain all these record and documentation. So it is documentation checklist as far as maternal part is concerned: physical examination, comorbidity, if any, emotional status, scan findings, presentation, placental position, gross anomaly, Liker amount, placental site, whether it was fresh IUD or old, it is also to be mentioned. As far as baby part is concerned, gender, birth weight, gestational age, date and time of birth. If it is twin delivery, then label twin 1 and twin 2 separately with placenta, cord, etc., and photo documentation. And if you have taken all these photographs with, of course, prior consent, many times it could be true note or retroplacental clot or macerated baby. All these document will be useful if at all you have to face litigation in court of law. As far as local protocol is concerned, in institute where you are working, labor ward register, stillbirth register, stillbirth certificate, if it is notification on part of government, then all the instruction we have to follow as per guideline from that very institute also. And ensure discharge summary provided very accurate. So discharge summary should be with all the information and about all the investigation or treatment we have offered to the patient. Preventing future recurrences. It is very important. If patient is very faithful, patient will come to you again, and very important question will be, will it happen again? What should be done not to have this type of experience again? So preventing reoccurrence is very much important, because 592,000 stillbirth per year in India, and out of those 50% are intrapartum, 43% are growth restricted. Can't we prevent this? We should be very we have to concentrate in this area to check this IUFD and stillbirth. So strengthen antenatal clinical screening, risk stratification. We should be very clear since beginning. Antenatal pickup is key to management. Clear referral algorithm. If at all patient is having any comorbidity like GDM or HDP or severe anemia or severe IUGR, they should be referred to proper center to take care, and patient party should be explained in detail, because many a time they are not serious about the condition and it may end into IUFD or further morbidity or mortality. Also, protocol based management we have to go with. Skill training and equipment for management, moral support to the couple, and there are some factors we have to avoid as far as this perinatal death is concerned. Patient delay in admission. Many a time when the labor pain start, patient reaches late in hospital, and even after reaching hospital, many a time treatment starts little late. Delay in care on admission to birth facility, delayed operative delivery, unavailability of health workers, inadequate intrapartum monitoring, misuse of oxytocin. It is very common finding that it is misuse of oxytocin leading to IUFD. Neonatal resuscitation failure. This is also one area. So our ultimate goal is by 2030, our stillbirth rate should be less than 12, and we should be prepared for that. Government is also very keen, and WHO has given us this target. And being a obstetrician, we are the direct person concerned to deal with the subject. So you were born silent, perfect, and beautiful, still loved, still missed, still remember every day, still born, but still born. So, question to face in this type of situation: was it preventable? If at all we are facing this type of cases in court, a very important question on part of prosecution: was it preventable? And if it is yes, one more question: what did you do to prevent it? Why you couldn't prevent it? If at all you couldn't prevent it, then why you couldn't prevent it? Did you diagnose that very complication or IUD well in time? And did you manage way in which any prudent gynecologist would have managed? If you can answer all those questions, then even if facing case of IUFD or stillbirth, you could be out of problem as far as litigation is concerned. Every IUFD cases are potential threat as far as this part is concerned. So what to do and how to prevent very quickly: practice foreseeability, anticipation, good communication, valid consent, and proper documentation, and you will be simply sail through. As far as anticipation is concerned, court and law expect to anticipate certain conditions from us. Say, for example, if it is a case of GDM, if it is a case of HDB, it is known that IUFD may occur. So in these cases, we should anticipate and we should be readily available to deal with the situation. Naturally, in all this situation, proper counseling is very much must. No rosy picture, no tall claim whenever you are dealing with any pregnancy with comorbidity, because we consider result like Aishwarya Rai, but it may turn like this at any time. No tall claim, no rosy picture, because in eye of law, when you claim to be master, you are supposed to be master. And naturally, records are always your rescue. So all the record of treatment given or treatment plan should be available to offer in the court whenever you are facing the litigation. There is always a way. So to conclude, always confirm IUFD by sonography. Breaking the news of IUFD should be done very carefully and compassionately. It can help us avoid a lot of medical legal issues that can develop with these cases. Investigations are done primarily to find out a cause of this IUFD. In spite of all test, cause is not found in 25 to almost 60% cases. History taking is most important part of evaluating the case of IUFD. Vaginal delivery is preferred route unless it is contraindicated. Use of prostaglandin with caution in scarred uterus with IUFD. Cytogenic evaluation will be helpful where no apparent cause is found. A postmortem may be advised in certain cases, and fetal autopsy can provide an insight to the cause. Be very vigilant in next pregnancy. Continuous support and reassurance is required in next pregnancy. And in any case, never take pregnancy beyond 39 weeks in women with history of IUFD in previous pregnancy. And we have to strictly adhere with pregnancy and labor room profile and protocols and checklist, proper counseling and consent, proper documentation, multidisciplinary approach. Whenever it is needed, do not hesitate to have a help from your professional colleague. No compromise on statutory requirement as far as management is concerned. And naturally, professional indemnity in era of CPA is very much must. So be vigilant in your practice. Otherwise, be ready to face this type of situation in obstetric practice. Comply with provisions of law. Formation local level medical legal cell is very much must. Just I mentioned prior also, because in need of time, one can avail services from that cell, that in case of surgical assistance, at the time of declaring bad news, at the time of mob violence or facing litigation, you can avail services of RUSH team, which should be in each and every gynec society. Take medical legal advice from point one if at all you are facing this type of problem, or if you are in doubt that you may face this type of problem in that very case. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. So God bless you. Have a litigation-free medical practice, because in spite of all these professional and occupational hazard, our journey to serve human and mankind is always on and on. So I conclude with this. If you want to sleep like this, take tender care of your patient. Pray Almighty God before going to sleep, and keep my visiting card below your pillow. So with regards, salute to all, and humble appeal to endorse my candidature for post of President Foxy next year, election year 2026. Thank you. Thank you very much. Please do not assume. Please ask if any query, any questions, if chairpersons and time permit. Thank you. Thank you very much.
Thank you,
Thank
sir,
you.
for your nice talk. Over to Kuntal madam for the expert comments.
Yes. Thank you, sir. As I predicted, you covered everything so nicely. And I just had one question. So placenta we can send without permission of parents, right? So we have to.
Consent is to be taken every time, whichever investigation we offer.
Okay. And if they are not willing for post-mortem or further investigation, do we have to take negative consent?
If we take negative consent, it is better, because if at all we have to face litigation, then it becomes good defense in your favor. Because if patient or patient party do not follow your instruction, it becomes contributory negligence on part of patient. So it is always better to have a negative. But many a time patient or patient party are not ready to give negative consent also. So in this situation, you can have signature of any co-patient, any visitor, that it was explained to patient and patient party to go for autopsy or any further investigation, but they were not interested.
Okay, sir.
Gopal, sir, you want to say something? Sir, you are muted. Sir,
Please unmute.
unmute.
Gopal bhai, you are muted. Please unmute.
So there's a mic button. You have to just click on that.
Yes.
Sir, sir, autopsy facility in periphery many a times not available or not be feasible. Then what can be?
So few of our friends are doing autopsy. So if patient and patient party are willing, then you can refer that baby with all due care and caution to reach to that our gynecologist friend, and they will go with autopsy and they will give all the detailed report. Say for example, in Ahmedabad, Dr. Prasant Acharya is doing autopsy very regularly. So if you can contact him, he can assist you in this situation. But again, patient and patient party should be ready for the same.
Sir, can you post a list of doctors in India who are doing autopsy for everyone to?
We will have to collect. As far as my knowledge is concerned, Prasant is doing.
So because from Rajasthan or east or west, east, north or south, sending to Ahmedabad won't be feasible.
But let us try. This is good suggestion. We will do this something in this direction.
Few labs are doing, so we can contact them. They'll arrange for the pickup and transport.
Yes.
Can I just add something?
Oh yes.
Dr. Monica, I'm Tamkeen from the Stillbirth Society.
Yes, ma'am.
And I think it's a very good suggestion that we should make a list and it will be available on our website. Thank you so much. We'll do that.
Thank you, ma'am. Thank you. It will be a very good help for the obstetricians working all over India.
But Tamkeen Khan, madam, if you can share it to me, I can put it on Foxy website also.
Sure, I'll do that.
One can have a look at any time.
I'll do that.
Yes.
Then now should we proceed to our panel discussion?
Oh yes.
Now we are next part is our panel discussion on unexplained IUFD, and our moderator is Dr. Pankaj Desai sir, and experts are Dr. Neelam Agarwal and Dr. Tamkeen Khan. Please put the CVs. Dr. Pankaj Desai is a great academician, teacher, scientific researcher, and inspiring public speaker. He is based at Baroda and he was a former dean over there. And he has given many guest lectures, moderated many panels, and many academic papers are to his credit. Next. Professor Tamkin Khan, she is from Aligarh, and she has given 330 years in teaching experience and guided 45 MD, MS student and PhD thesis. Dr. Neelam Agarwal, next. She is from Ambala. She is a professor in Chandigarh and founder president of Stillbirth Society of India and past president of Indian Menopausal Society. Next. Next. We have got eminent list of panelists. Dr. Devendra Parmar, President Bhuj Society. Dr. Nalini Anand, Professor of OBGY, MP Shah Medical College, Jamnagar. Dr. Piyush Vadalia, President Junagadh OBGY Society. Dr. Hira Kodiatar, President Porbandar OBGY Society. Dr. Jigna Gantara, President Rajkot OBGY Society. Dr. Deepak Bagte sir, past President Sogok. Dr. Kartike Shastri, Secretary Rajkot OBGY Society. And least but not last, Dr. Jignesh Deriwala sir, Honorary Treasurer Sogok. Over to you, Pankaj sir, for the moderation of the panel.
Thank you. If this screen goes away, I will be able to share my screen. Yeah, thank you very much.
Yeah, so you can share now.
Yeah, I'm seeing a beautiful face there and some names there. I'm sharing now. Just a second. Sorry.
Your slides are visible. It is not full screen.
I am also wondering ये जादू कैसे हो गया?
Sir, you need to click on the button which is there on the extreme right.
That extreme
make
right
it full
button is to
screen.
leave.
The right corner on the lower end, sir.
Which button?
So just near the volume switch, there is a slideshow button on the right lower corner.
Just a second. I don't see it. So
there's a tableau like inverted U type button.
Or you can go to, okay, to icon just before the slideshow. You click on the slideshow and then start presentation. Yeah.
Yep. No, I restarted it. That is, the best thing here is in this is to restart. Okay.
So this is the ice cream like, yes, sir. This is the button.
Yes, this is the button. Yes.
This is the button, ice cream cup shape.
Yes, now it is full screen.
Okay. Just a second. Okay. Can you see now? I am ready.
Yes.
Okay. Thank you. Can you hear me?
A bit closer to the mic, please.
Then my hair, which are dyed, can be seen. So I am trying to avoid that. Okay. No, just joking. I can. Do you want me to increase the volume, or is it fine?
No, sir, it's okay. Fine.
It's
Fine.
okay. Thank you. Because till date, nobody has objected to my volume being less. Therefore, I was never popular with girls in our class. Our class girls still lament. Dr. MC Patel, sir, thank you very much. Enjoying your side effects of your drug. The drug is presidency. In last 2 years, 3 years, so much teaching he has done. He has shared knowledge all over the country, and not only that, I have been a party to many, and I, whenever given a chance, I see to it that I take a tough topic, so that with Dr. MC Patel, I also learn. And thank you, sir, so much. Tamkin, seeing you after such a long time. God bless you. And Monica Ben and Devanand Parmar and Nalini Anand and Piyush Vadale. I am sure all of them must be there. First, let us start with a prayer. Seeking refuge in Shanti today, may I find solace in the simple moments of life. Feet on earth, bird songs heard, or affection received, may subtle solace be found in life's unrest. Solace in life's unrest is the topic for today. Unexplained IUFD. This is the unrest which makes us very much fearful. So the questions that were being asked when Dr. MC Patel finished his lecture, I could see only one thing: fear. So much fear. And when this situation occurs, all the more reason you have no explanation. Suddenly the patient comes absent FHS. First response, fear. Don't be afraid. When knowledge walks in, fear goes by the side. We are going to have a panel discussion. For me, this panel discussion is always like going to the battlefield and learning from our teachers. Our teachers in Indian culture are called gurus. Guru Brahma, Guru Vishnu, Guru Deva Maheshwaran. I see wonderful names, some of whom I have known for decades together, some for years together, and some names I am seeing for the first time. And they are going to take us to the battlefield and make us learn what happens and how we can handle it. Fetal death, by strict definition as a teacher, only one slide that way, is a spontaneous cessation of cardiac activity after 14 weeks of gestational age. And its rate is 2.02 per 1,000 births. So in an average setup, maybe you might get this 1 in 10 years. Don't be afraid. Become scientific. Yes, in large hospitals you will need, because deliveries are more, but even small, where I was working 5,000 once upon a time, expected. But here, in day-to-day life, while most of the causes can be identified, some cases remain unexplained, even after postmortem. Now that is where the thing comes. It is right, out of fear we were asking, sir, who is doing postmortem? Who is doing postmortem? I understand. You may not require in your whole life, but good people like Tamkin, Dr. MC Patel, benevolent people are ready to put that information. But don't be afraid, take it as information. Because even after postmortem, there will be unexplained cases. And that is what I am going to touch as to why that fetus died. Let us decode. Why unexplained, without any known reason, the fetus dies. The topic you will accept. Teachers like Tamkin, all the more. Teachers like Dr. Nalini Anand, all the more. This is a tough topic. This is not an easy topic. To take you people into science from things which are unexplainable, where mysticism comes in, where magic comes in, there to bring in science is so difficult. Let us see now. I am opening this up. Anyone, right from Devanand sir to Jignesh Deriwala, anyone in the list of panelists can answer, not directing it to anyone else. When details of a danger remain hidden, we always tend to identify the risk factors. For example, Himalayas are very young mountains, very young. Therefore, so many earthquakes. Therefore, we don't go to the Himalayas usually during monsoon. That is a high risk factor. We don't know why it occurs. There is definitely evolution and different processes taking place. But here also there are, whenever we cannot know the cause, we identify the high risk factors. Can any of my teachers on the panel tell me, sensitize us to the risk factors of such disasters so that we can become more alert? If this comes, we are alert. Please, any of the teachers, please.
Good evening, everyone. Like sir has very rightly said, that there are lots of reasons and yet it is unexplained. To just complete the list of lots of reasons, we can divide them as maternal factors, fetal factors, even the placental causes, the cord causes, some genetic causes, infections, and again to complete the list, unexplained. There are multiple causes for IUFD. That
High
is
risk factors.
simple.
I want to know the risk
High risk factors would be when the mother is of an elderly age, more than 35 years of age. Yet again, even teenage pregnancy is high risk for stillbirth. When the mother is predisposed to risk factors like hypertension, that is maybe it is
That is explainable.
pre-existing
That is
or
explainable.
yes. Then diabetes,
Explainable.
for what reasons we don't get. Then history of previous stillbirths, that again still remains questionable and again can recur. In some cases, if there is fetal growth retardation, those cases also are prone to end up in this type of disaster. One of the multiple pregnancies can at times remains unexplainable because
Yes.
one fetus is growing properly and one gets dead, maybe
Wonderful.
something
Wonderful.
chromosomal. Then
Dr.
some,
Naliniben, I seek your indulgence in this. Do you agree to
pardon?
this? Do you agree to please see the slide? Older
Yes, sir.
mothers have a high risk, as you say.
Ye-
But
yes, sir.
can consanguinity, which can
Yes, sir.
technically increase
Yes,
the risk of genetic
because
anomalies?
of genetic predisposition to risk factors. But
Okay.
yes, again, sir, I would say we all have seen couples who have one child stillborn and then again second child is normal or
We
maybe
are
and
coming
vice
to that. We are
versa.
coming to
So
that. Don't worry. We
the
are coming
cause
to that.
remains
Family
unexplained.
history of cardiac problems.
Yes.
Can that be family history? If that, who asks? Brilliant teachers like Nalini Ben may ask, Tamkin may ask. Okay, brilliant people like MC Patel, when he stands in the court, he may ask, do you have a family history? Some studies have linked IUFD to genetic variants associated with heart conditions, and that
Yes,
can
sir.
be explainable.
Especially arrhythmias, they have
I'll be
linked
coming
some
to that.
studies
I'll be
have
coming to
linked.
that.
Can I
Yes,
can I
please,
add some?
Deepak bhai, please.
Can I add something? Okay.
Yes.
Absolutely. The risk factors which Nalini identified are absolutely. I would agree to all of them. The question is, in these patients, we are always careful. The question comes not in these patients, the other 50% of the patients where we tend to relax a bit. And this is the problem where IUFD occurs.
Yeah.
You see, this is, I mean, in these patients, we are always
a
careful.
condition where we have so much to imagine. And that condition, Deepak bhai or anyone, Nalini Ben or maybe Piyush bhai if he is there, or Jigna Ganatra, I have already seen her, if she is there, we come to thrombophilia. I have to speak somewhere on thrombophilia, so I might be more prepared. But then I leave it to you to tell me.
Okay. See, thrombophilia.
Yeah, what do you think of the thrombophilia? Third trimester, IUFD is significantly associated with thrombophilia. Your kind
Thrombophilia.
inputs on this, please.
Yeah, thrombophilia is thrombus. I mean, let us put it that way, very simple. Thrombophilia will cause the clotting and thrombus. And then thrombus anywhere is going to cause infection. Infection either the placenta or what? The blood supply. So the question is maternal, placental, or cord. Here the placental is directly affected because there is going to be infection also. And say basically, if you see thrombophilia anywhere in the body, whether it's a heart or a brain vessel or whatever it is. So in fetus, thrombophilia is certainly going to give you a lots of problem.
Especially if it causes the placental vessels.
Jignaben, I would like to ask you on the wonderful input by Deepak bhai. Jignaben, there was a paper in 2002 in obstetric gynecology. I happen to be a reviewer there now. There was a paper with a title, to the best of my knowledge, third trimester unexplained intrauterine fetal death associated with inherited thrombophilia. And there they suggested that thrombophilia workup should be part of IUFD investigations and may have a therapeutic and prognostic implication. Should every patient who has an unexplained IUFD, please consider my words, unexplained, should they have thrombophilia workup done?
Yes, sir. Basically, I have come across at corporate hospital in many of the patients, and what typically even if we do not find any reason, then we usually advise bad obstetric history profile and all. But only thing is, three investigations are very important: lupus, beta 2 glycoprotein, and anti-cardiolipin antibodies, IgG and IgM. And among these, in many of the patients we may get anything positive. Typically lupus is very bad thing with fetus also. That's what I have come across clinically. So
Okay,
thrombophilia
I'm not
workup
going into details of
definitely
this, only a
required.
small additional comment. IgG and IgM measured, people become hakka bakka. Because when it is in infections, IgM means something which is old, IgG is old, gone, M is what can kill now, present. Mari sakete. Here, don't worry, even if either of them are positive, it's positive. Deepak bhai,
Yes,
you agree with
sir.
me, I
Yeah,
presume.
absolutely.
Thank
Because
you.
see,
We come to a tough area. The only two areas which we used to take in option in MBBS was genetics and immunology. I fell in love with both these topics in MD, and here I am bringing a tough gene. Angiopoietin 2 is a potent regulator of angiogenesis, construction or creation of vessels and vascular tone. And Deepak bhai insisted, and Nalini man also insisted in her reference to placenta. Is a protein that plays a crucial role in angiogenesis. Will my teachers tell me? We are on unexplained IUFD. Angiopoietin 2 gene polymorphism in unexplained IUFD, any role?
of course,
Of course.
Yes,
I mean
sir.
the blood vessels are not formed.
Not well
Simple.
formed. Not
Though,
if at all formed structurally, functionally not competent.
though,
And
sir,
there is
limited evidence is present
Nalini,
about
we
this.
want to see your face. Don't chup mat jana.
Sir, though limited evidence is present in this case, and lot of more studies are, I mean, some evidence is needed. But then, whatever studies are available, they do show that this angiopoietin 2 gene polymorphism, it has got increased linear relationship with the IUFD, especially when there is placental insufficiency or fetal growth restriction.
Thank you. Excellent. Here, there was that paper which you referred to was a 2005 paper. Therefore, understandably, Nalini, your point was right. It can even run in the family. It is expected to run in the family.
Yes.
So once again, a history will come here. And not only in angiogenesis, what happens is, Deepak bhai, when you said the vessels are not well formed, sometimes the vessels are well formed, but the lymphogenesis,
so
they are also involved in lymphogenesis. Now, what you are going to see in that postpartum? I end up
nothing.
worry.
Nothing.
Suddenly, the baby has an unexplained IUFD, and you send for postpartum. Prasad bhai will like to help you. Tamkin will like to help you. But
Nowhere.
no, you can hardly. And I'm still keeping you in a tough area.
No.
My message is every time don't abuse yourself. Don't criticize yourself. See how deep this subject is. And one of who initiated me to discuss was a patient, was our colleague, somewhere in the east of India. She emailed me that, sir, I had such a disaster. Please prepare a lecture and put it on your YouTube channel. I have put it. But today, when MC Patel told me, I said, yes, Manu bhai, I want to discuss this aspect. Unexplained.
Yes.
खबर जो पता ही नहीं चलता, खबर नहीं पड़ती. Now cardiology comes in. And what cardiology? Cardiogenesis.
Can I comment on angiopoietin 2, Dr. Desai?
We'll come to you soon. We'll come to you soon. We are now on cardiogenesis. Unexplained stillbirths may be caused by cardiogenetic pathologies. A high number of variants of uncertain significance need a more detailed postmortem examination, including family segregation analysis. And I'm sure you will understand that whether this level of postmortem is possible in our setup. That is, I'm leaving this message to you. But I am now coming to one more quizzical area. and that is maternal heart rhythm. Can maternal heart rhythm kill her unborn child?
Arrhythmias.
Arrhythmias. Arrhythmias. Nalini Ben is well prepared. There is a smile on her face. I can make out a teacher that typically she is. Do you still teach, or you have left the medical college?
No, I'm outside the
Sir,
practice.
I am,
No. Nalini Ben.
Sir, I am professor and head of gynecology in MP Shah Government Medical College.
Okay, right, nice. So therefore, there is a smile on your face. Now I am coming to your comment on this. Bundle branch block, QT prolongation, torsa de point. It is pronounced as torsa de point. You must be, many of you must be knowing French like me. In the mother can lead to cardiomyopathy, and in the fetus, sudden unexplained death.
Yes.
Your comments on this, please.
Sir, if the mother is having some structural cardiac genes, like if there is a history of familial history of hypertrophic cardiomyopathy, and which is because of mutations which affects the cardiac structure, then, or if there are possible history of supraventricular tachycardia or a complete block, then these are the cases which are risk factors for the same in the fetus. Arrhythmias, sudden cardiac deaths in the family. Definitely, we do not know, none of us generally ask these things in the history, but yes, it's a very important part in the workup of IUFD.
Yes, your MD question next time. Neelam
Can I-
Agarwal may like to add.
Can I add one more
Yes,
thing?
please.
Even the congenital heart disease in the mother, not only the arrhythmias, even a congenital heart disease, it may be a genetic predisposition sometimes.
Okay.
So we got to
Yes.
think about that thing part also.
Okay. Neelam?
Yeah, let's first, I will just say about cardiogenetic, then about angiopoietin 2. Cardiogenetic causes, arrhythmias per se, they do not kill the fetus, but if arrhythmias are associated with maternal shock or maternal hemodynamic instability, then of course they will lead to IUFD.
Correct. So statistics have shown that this is the association. All associations are not necessarily causations.
Yeah.
That is what you mean to say. That
yes.
is well taken. But when
Yes.
this occurs, our practitioners can be alert that there is an association like this. Fine, go ahead.
Yeah, and secondly, angiopoietin 2, in earlier studies, it was thought that it is associated with IUFD, but later studies, they have shown that Caucasian population, not much associated. But of course, in cases of unexplained IUFD, the most important thing is that it should be really unexplained, not the unexplored or uninvestigated. Once all the investigations have been done and nothing has been found, then we can go ahead with
Madam,
these
these are
rare.
the cases and situations which I am bringing before you. They have been, after all these have been explored.
Yes. So in those cases,
please,
we must not
all
leave.
this hard work is after all the causes have been explored. Fir kya bacha?
Yeah. In those cases,
So
we
I understand
must.
your philosophy. I understand your philosophy. But this science tells that this has already been covered. We now come to torsa de pois. Just for the audience, this is where I am converting myself for a few seconds into a teacher. It is a specific type of polymorphic ventricular tachycardia that can lead to sudden cardiac death. It is characterized by a twisting. I'll show you the twisting pattern. A twisting or oscillatory pattern on the ECG where the QRS complex seems to twist around the baseline. Here you can see a typical torsa de pois. All these can add, and you should be prepared that yes, if you see this on the ECG, whether you will see on the ECG first, therefore the importance of such panel discussions. Yes, I had heard this somewhere. This could happen. And when
Sir,
Dr.
even in
Neelam
few cases
said,
of
when giving a
WPW
very
syndrome.
comprehensive view, the consistent villain, a villain unparalleled in Hindi cinema, and the villain in our practice, the placenta and the cord. We come to this now.
Sir, even if I may add, even WPW syndrome, if it is associated with the arrhythmias, that also
We'll come to that. At the end, we'll come to role of umbilical cord stricture and hypercoiling in unexplained IUFD? Any of the teachers can tell us something on this.
Yeah, cord stricture.
Logically,
I mean, genetically and the Wharton jelly. Some patients you see a very thin cord sometimes. I mean, that is after delivery you find the cord is so thin that there is hardly any Wharton jelly. So this is one patient, or probably there is a long cord and the coiling is quite a lot. But whether they really cause mechanical pressure or not is
sir,
not.
Yes,
Yeah.
Nalini?
logically, we can say that when there is compromise in the blood flow, maybe it is because of hypercoiling, or if it is because of stricture, that obstructs the blood flow, and then hence increases the risk by causing this fetal distress. It can cause the intrauterine fetal death.
You
We
are
may not be
making
able to, because at that
you
point it is hypercoiled. Many times we have seen long cord which is associated with multiple loops of cord around the neck. Many of these babies, they
that is
even deliver
explainable, but
normally,
we
many
don't
deliver
see
cesarean
this.
section, and many times
We don't
death.
see this. When there is a death,
Yes, we do not.
IUFD, just as Dr. Deepak Bhai said about the Wharton's jelly to support the structure, the vessels there, we don't see for cord strictures and
Yes.
hypercoiling.
So I think, like Dr. Neelam said, it is maybe not actually unexplained, but maybe unexplored. Yet
Okay.
few
And
testings.
umbilical cord stricture and hypercoiling seem to be significantly more common in IUFD. A 2018 picture is shown, and I will show you the picture, actual picture of umbilical coiling.
Hypercoiling.
Hypercoiling. And there is also a umbilical cord coiling index. I'm sure Dr. Nalini must be asking this in her short notes to DGO students. And I never asked it because I hardly became an examiner. Good teachers, that is my feeling, good teachers usually don't like to take exam. So I wanted to be a good teacher, not necessarily that I was. And Tamkin will bear with me also because she is also from, she is my colleague as once upon a time I was in academic teaching, still in academics. Now, determination of the umbilical coiling index is considered to be a part of full placental examination. When you see an unexplained IUFD, then we can suggest from this panel that please calculate the umbilical coiling index, which is calculated by dividing the total number of complete 360 degrees coil by the total length of the cord in centimeters. Do you agree with me? Because I am talking here as a student.
Yes.
The student can ask more questions about why
Yes, normally it's 0.1 to 0.3 coils per centimeter.
Let us put it at 0.1
to 0.3 coils per centimeter, and if more than 90th centile is hypercoiling and less than 10th centile is hypocoiling.
So we have to see the graphs for that, right?
No, but easiest way, I think the easiest way.
Or we can say, if it is less than 0.1, we can say it is hypocoiling, and if it is more than 0.3, then it will be
hypercoiling. Yes.
Fine. That is excellent. The absolute figures really help.
See the 0.1 and 0.3, I mean, I can understand it's easier, but easiest way to remember is 3 per 10 centimeters.
Yes.
Okay. Just corroborating with, and you have already agreed that if a cord has 5 coils and a length of 50 centimeters, the UCI will be 0.1. And if a cord has only 1 coil and a 50 centimeters, the UCI will come to 0.02. Lesser the UCI, safer the cord. Am I right?
Yes.
Yes.
I'm coming to Deepak Bhai soon.
Yes.
Yes, okay. Now, umbilical UCI above 0.3 is associated with IUFD. The rule of thumb, as Deepak Bhai, very practical all throughout in private practice, though originally in teaching, like my wife, very practical. A rule of thumb, in general, a practical guideline is this, that if they are more than 5, then be alert. This could have caused a problem. We now come to the viral etiology. How important are the viruses in causation of, especially the enterovirus, in the causation of unexplained IUFD? We were not knowing, we never knew. Can this be? Your comments, please. Teachers' comments.
For that matter, any fever, I would say, okay, the viruses would come later, but for any fever, for that particular days of fever, it is always risky for the baby. And those are the patients we really cannot do anything till the fever comes down. And we have seen a lot of time during the fever, the amniotic fluid index goes down drastically down, if you notice in sonography. So enterovirus will come later on, but I will tell you one thing also, sir.
Any infection.
Yeah, and the only thing I would say, all viruses do not really cross the placenta, including the enterovirus. 50% are somehow, they cannot cross. I don't know why. But
in fact, sir,
Their molecular size.
if you all
It is
remember,
very simple. It is their molecular size.
so the thing is, yeah, so there's a thing. So
play. It is understandable.
the
if we
question
all
will be,
remember, during COVID period, Corona period, we all were experiencing unexplained oligohydramnios, unexplained intrauterine deaths, which were very common in those days.
so
And I would like to add with H1N1 also. We have come across many of the patients clinically, sir, swine flu positive, COVID positive. Everyone was associated with this.
Thank you. Excellent. Thank you very much. Now we come to the investigation. We have seen the causes. We now come to a bird's eye view of investigations. Which investigations would you like to recommend? There is an unexplained IUFD.
For IUFD,
Patient that, as Manubai said in his last case, that they are friendly with you. They will come to you yet again. They have come to you. What has happened has happened. No problem. What investigations you would like us to carry out?
So can I divide into three? The maternal part, the maternal, what cause was the fetal or the cord complication? So easiest would be the maternal, unless it is a preeclampsia, because these are the patients where recurrence is going to be there a lot. We'll be very happy. We really have to go for the genetic testing, and genetic testing does not mean the karyotyping now. It has to be a microarray or a complete gene frequency. I wish, at that time I had taken, or someone else in my family had taken genetics as a profession. Nowadays, genetics are so much in demand, and they're going to be in demand. In fact, if you have got any children,
very exciting.
Before 10 years, there were hardly any fetal medicine experts. Now there are plenty. But look at the number of really good genetics people who are available. Hardly. So personally, for doctors now, I think genetics is a really a branch where some students should really pursue. And if you see obstetrics,
and sir, like we discussed, we could include maternal echocardiography into our list of investigations for IUFD.
Especially if you're going to play, especially if you're going to.
Brought, as per my thinking, this list, you have added quite a few. Anything else you would like to add to this?
Sir, I would like to, if the relatives are not in a good mood and all, still I insist, if they are willing, at least for cost purpose and all, DNA storage, sir, करवा लेने का. उनको explain करके storage, DNA storage is not costing much. In the future, if they want to evaluate after 1 year or something, then we can always investigate. DNA storage के लिए तो only fetal tissue, little bit of that is required, or either placental. That's what they say.
And sir, nowadays NT scan is a common thing. So we can even include whenever we see the NT scan, the rectal translucency is higher towards the higher side. Maybe we make it a point ourselves to closely monitor those fetuses, because there are studies which point that NTs with higher translucency thickness, those fetuses are at increased risk of IUFD.
Excellent. Thank you very much. I'm coming to a controversial area now. Solely for the prevention of fetal death, I'm going to list certain things. Please be very clear and tell. Have the courage to say no role or role. Maybe, may not be, no. Why? Because the reason I'm insisting in this is, that was the reason 1 week back, I have given the questions already. And you can see it is reflected in the quality of answers which we are getting. Even inputs from Dr. Neelam and all. excellent answers. I don't know whether Dr. Kodiatar or Karthik Bhai or something are there, someone are there. But whosoever are there, please tell us. What do you feel? Solely for the prevention of fetal death? Rest? Next time they will rest. Or now also, there is no risk factor, but you are afraid, she is afraid of fetal death. How much does rest help?
Not much, except it is a twins.
Maybe it can be harmful at times because
Harmful at times.
pregnancy is a
Thank you. So does not
hypercoagulable
help.
state.
Thank you, Deepak Bhai, and
Yes,
thank you,
sir.
Nalini Ben. Aspirin only for prevention of fetal death.
Before 16 weeks, if it is given.
No, sir.
We start.
Data, sorry. You are the teacher.
Okay.
Data has shown recently that it will not prevent a fetal death. It will not prevent
Sir,
a
it has
fetal
got
death.
No, it
only
will
when other
not.
things have been ruled out.
No, indirectly, if you can prevent preeclampsia, indirectly it can do it.
Yes,
Otherwise,
It
no.
is an unexplained area, but that is an explained area.
Yeah, there
Vitamin
is an
A,
explained area. That's why I said that those explained areas are simple to treat. This is the extra.
Vitamin A and
only
D.
if,
No.
sir, A, no role as
D,
such.
no.
D, there are few studies which say that deficiency of vitamin D is associated with lots of coenzyme activity which affects lots of functions of human body. Nothing per se about fetal death.
No.
Taking cognizance of that, I'm sure you are also very well read. A recent review article has come in which only one paragraph has come. Rest of the article is on so many other things of vitamin D in obstetrics, which clearly tells that no, we don't have enough data. I will take it that way.
No.
Vitamin D, that we do not have enough data.
Vitamin D is, I don't know, since last 3-4 years, vitamin D has been considered as jadi booty for everything.
Yes.
So I don't know how much that can be true. Of
That
course,
article says there is not enough data.
no, I'm sure.
Micronutrients.
Probably, yes.
Micronutrient deficiency definitely should have some role because some of them are involved in lots of deficiencies. Not that you give supplementation that will prevent fetal death.
Okay, brilliant. That was a nice one. Looking for knuckle cord during prenatal screening of ultrasound, and
No.
this is where Nalini Anand. Nalini, I am aware of this the stand which you have taken, but the data still is not
No, I would say
Insufficient.
no.
Definitely,
No,
sir.
sir.
I don't think
No.
there is no
No.
sufficient data, but I have read somewhere that some people have quoted that when their knuckle translucency length is more, they are more prone to. I definitely don't have. We don't have much data on this.
Thank you very much.
In fact,
And nuchal cord around neck should not be reported also till it is full term, sir.
Okay.
So at 32 weeks, if it is cord around neck, then there is no significance.
No
That
significance.
is what.
And repeated antepartum monitoring by cardiotocography. One of our friends is a surname starting from M, I think, spoke because
Morjaria.
repeatedly performing antepartum monitoring, does it by cardiotocography, will it help?
In cases of IVGR and
no
preeclampsia.
preeclampsia, nothing. बस आपने दर
No,
Recommended, it will falsely increase the cesarean rate, sir.
Yes,
Or it is
It will
not.
not help in preventing cardiotocography.
So we will know fetal distress.
IVD.
We will anticipate fetal distress in lots of cases, and hence, like Dr. Jigna said, we will end up in doing C-sections.
So not recommended. Thank you very much for taking a very clear stand. Now we come to this. Recommended? I am coming to that. Vaccination against influenza in epidemic periods against SARS-CoV-2.
Yes.
So definitely it will help.
Fetal autopsy and entomopathologic examination of the
Yes.
placenta.
Yes.
Recommended.
Yes.
Not
Yes.
prevention,
Might
but knowing the
help.
cause. It is chromosomal analysis, microarrays.
Only microarray.
Thank you very much. And testing for antiphospholipid.
In fact, I'll put all apply together. Yes.
Yes, thank you. Now we come to the mother. I hope MC Patel sir will allow me.
Can I add one more there?
Yes, please.
If required, gene sequencing.
Gene sequencing. Okay. If facility available, gene sequencing. Yes. Thank you very much. Now, management of the mother. I am not going into the medical legal part of it. I am going to the human part of it. Our Manubhai, Hitesh, and our Sharma Sai Gitendra have really helped us a lot. I am coming to the human part of it. Announcing the IUFD to the mother, how and anything to be kept in mind.
Correct,
Sir.
obesity, anemia.
Sir, like Dr. MC Patel sir said, the key is communication. So we have to be, like sir also said in his talk, the senior most person should, I mean, we have to, that is all to have an empathetic approach, not only just sympathetic, but empathetic approach, and think from her side. She has carried this child for 9 months, and now we give her the bad news, and yet all the trauma of delivering the mother, definitely the empathy on our part and the relatives, and clear communication. Definitely we have to be very, very assertive. We have to keep all these things in our mind. We have to not show any haste in delivering. After explaining, we can tell her
I am coming
to
to
take
that.
her
I am
time
coming
to
to the
process
delivery.
the
I am
bad
coming
image.
to the delivery. Please wait. Please wait.
No,
I
I
am coming
mean,
the next section only. I am coming to that. Excellent
okay.
answer. Beautiful. Empathy is the word, not sympathy. Empathy. They are two different things. I don't feel. I am not in a position to feel, ma, what loss you have suffered. I cannot feel it, but I can stand by you. That is empathy. That is empathy. Excellent word used. And any consideration of timing between the fetal death
Sir,
diagnosis and
sir,
labor
we need to
induction.
give some time to the mother to process what we have told her.
Okay.
हमारे पैनल में हेल्थ
Somebody's microphone is on. Henry Kissinger's microphone was on at White House dinner, and so many scandals came out. Returning home. Can she return home after hearing the news?
Not immediately.
Not immediately, okay? In the absence of risk for DIC or maternal demise, the patient's wishes regarding the timing between the fetal death diagnosis and labor induction should be considered. Return home is possible according to mother's wishes. Do you agree?
So I don't think it will make any difference whether she returns home or not. The main thing is that we should not pass much of the time after the diagnosis of that it is an IUFD and the delivery. But then at the same time, being empathetic and not hasting is also the key, because we need to understand that it's not easy for her. And if for that she wants to get comfort of her home and be near her relatives for maybe few hours, it's fine. But we cannot just send her back home and tell her come after 2 or 3 or 4 days. It's okay. That should not be the case.
Okay. Okay.
And usually, practically, what
No,
How to deliver?
no. The thing is, okay. The previous slide, the Pankaj Bhai. What I was saying, we have the way of telling the patients, the IUFD che, the patients always feel that mane jher chadi jase. I will die because there is an IUFD baby in the mother. So we got to make sure, we got to tell them nothing happens for first few days. Nothing is going to happen to you. So at least wait for a normal delivery, wait for induction. Don't hurry up for a cesarean section, because patients and the relatives feel that there's something going to be wrong with the mother as soon as IUFD baby is there. And
Exactly. That is the
this
truth.
is very prevalent in this
exactly.
part of the country. I don't know what about the other part, but here it is very prevalent. कि जड़ चढ़ी जासे. Patient baby has died,
It
so mother
is
is also going to die.
Okay. One
it
academic
is
information
always
on
that
this. One academic information on this. The fibrinogen levels reduced to half after 3 weeks.
Yes.
Yes, sir.
Please.
Yes, sir.
So please
Sir,
don't.
but
Chair chali
hospitally,
jao means body getting poisoned of the mother is from this.
But then,
This
sir,
data has shown, and
sir,
that should
that
be
is
reassured.
also true. But sir, that is also true in cases of IUFD, like the first case which Dr. MC Patel sir discussed. We all have witnessed very fast there is deterioration of maternal health, and at times morbidity and mortality of the mother.
sir,
And then
sir,
though the books in
personally,
academics definitely they say 3 to 4 weeks time is required for fibrinogen levels to decrease and cause any harm.
Okay, thank you. So you have time. You have time that if
Sir,
she is
but practically speaking, sir, whenever as we have come across many of the patients, and specifically, it happens that in private gynecologist place, if IUFD is detected, then also they send the patient for all these. Many of the gynecologists are now not delivering also in private hospital. It is always practically speaking, with the current scenario of practice, I will never advise to wait for much more time. That's what I completely agree with Nalini madam. That is the
okay,
only
if she
thing, sir.
tells કે બેન મારે વિચાર કરવો છે,
Yeah, you
બે
should be
દિવસ
allowed.
ઘરે જઈ આવું.
Sir, હું એને
It is
લખી
allowed.
અને
It is
સહી
allowed.
લઈ લઈશ કે મેં એને એક્સપ્લેન કરેલું છે કે આમાં IUFD છે અને આને ટૂંકમાં દવા મૂકી અને આને આ બધા રિપોર્ટ્સ કરી અને ડિલિવરી કરાવવી જોઈએ. If they are not agreeing, then it's okay, પણ હું સાઇન લઈને ઘરે મોકલીશ સાહેબ.
Sign
We
lady,
should
okay.
not
As soon
waste.
as sign comes in, human face goes up. So law has no human face. You must have seen. I am not talking of that. મને કશું આવડતું નથી law ની બાબતમાં.
No,
એટલે
no.
please,
I
let
think
us go to,
let us
now let us
suppose
go.
if you
I don't want to discuss this further. How to deliver? All by scissors? How to deliver?
no induction.
Sir, IUFD per se is not an indication for
Not
cesarean
an
section,
indication
but
for
again,
cesarean
after this other
One at a
indications we
time,
need
please.
to see. Bishops, pelvic assessment, all those things we have to see. It is not IUFD per se is not an indication of
Thank
C-section.
you. Regardless of the previous cesarean section, the
Usually
recommendation is
labor is quick, sir. Whenever we induce, response is good in this type of patients, but
Yes.
only proper explanation to
એ
relatives
તો થઈ જશે
and
બેન, એ
patient
બધું
is
માની
required.
લીધું આપણે. પ્રોપર એક્સપ્લેનેશન, તમારે જેટલી સહીઓ લેવી હોય
હા.
એટલું લો. તમારે જે એક્સપ્લેન કરવું એટલું કરો, કથા માંડો, બધું કરો. We are not academics, madam. I am not talking of can this patient with the previous can this patient with the previous 2 cesarean section at 30 weeks IUFD will you deliver vaginally?
No,
Yes.
sir. No, sir.
Yes.
Sir, હું
Yes.
શું કરાવું?
Okay.
I
So
will say yes.
individualize the case. That will be the right answer. We now come to the recurrence. You are all talking of recurrence. वापस होगा, डर लगता है. चलो देखते हैं. Let us see about this recurrence. Does the recurrence, now your comments on this, the incidence does not increase in subsequent pregnancies except in cases where history of fetal death is due to vascular problems, and low dose aspirin is recommended to reduce perinatal morbidity in subsequent cases. In subsequent cases, data shows that perinatal morbidity will be less, and if the cause was due to vascular problem, if it was because of stricture, it was because of coiling, if it is because of something else, no. It will not increase. That is what I feel. What do you feel?
Yes.
Is that the chances of recurrence?
No.
Does not increase.
No.
We
That
become
does
so
not-
afraid. So
No, if it
last
is-
time there was a death. આ વખતે ના થવું જોઈએ. અમારા હાથમાં નથી. And I am sure at the stage of Nalini Ben or Neelam Agarwal or Deepak Bagde, હજુ જીજ્ઞાબેન ને થોડીક વાર છે. We are in a position to tell. We are in a position to tell in my consulting, madam. You are telling private. We both are also completely private. We are in a position to tell that we cannot prevent it by for sure. We will try 100%, and they see our sincerity for sure. Interval between this and the subsequent pregnancy. How much time should elapse?
Sir, ideally, it is always better that after 6 to 8 months or 1 year, if the patient wants, we don't deny them. We don't deny them to try for conception. But as per academics, as per the levels, it should be a gap of minimal 2 years. Yes, sir. It should be a gap of 2 years. But when if the patient comes conceived, we have all seen that they deliver well, and then their mental condition is also good.
I am talking of science. Scientific reason why you want to wait. Nalini is laughing away. She knows there is no reason.
I will wait till I'm satisfied that the investigations which are possible have all been done, and whatever was possible they have been dealt with. Then probably any time.
Nalini, you are a professor. You have a halo around you, so I cannot challenge you.
Sir, please.
But then this is only a data. No scientific need of delaying another pregnancy. More intensive fetal health monitoring is also not necessary. They indicated solely on history of fetal death, unexplained fetal death, or any fetal death. Just because last time she lost, this time she will lose. So you come every week, every 4 days, doesn't help. Doesn't help. If you want to do it, but doesn't help. And
Sir, in fact, I believe that this type of intensive monitoring can make the patient more apprehensive and more anxious and can add another factor to the adverse outcome.
Thank you. We will come to one special situation and then we will finish it up. And one of the I think it was mentioned by Nalini Ben also in her passing phase, fetal death in one of the twins. It is applicable to both the types. The surviving twin should be examined immediately upon fetal death diagnosis. Is it true? Do you feel so? The surviving twin should be immediately examined upon fetal death diagnosis.
Sir, not detailed examination. I mean, we have to just do antepartum fetal surveillance along with a coagulation profile surveillance. Like we all know, 3 weeks is required for fibrinogen level to decrease. So definitely the thromboplastin that is released from the dead fetus is going to cause adverse effect. And hence our decision of how till how long we can continue the pregnancy has to depend upon the coagulation profile of the mother. So rather than only examining the fetus, the mother needs to be examined.
Crops. We have one a child also as a participant. I think I would like to ask questions. Satabhi madam has someone. Day madam. Okay. In a monochorionic twin, Jigna Ben, in a monochorionic twin pregnancy, the surviving twin should be immediately evaluated for signs of acute fetal anemia with weekly ultrasound monitoring for the first month. Do you agree?
Yes, sir. Yes, sir. In
Yes,
a
sir. Monochorionic, definitely.
pregnancy, starting from 16 weeks, every 15 days, sir, monitoring કરવાનું અને પછીથી, sir, every weekly, definitely, sir, for twin transfusion and many of the other complications are associated with this. So I definitely recommend monitoring every 15 days starting from 16 weeks of pregnancy, sir.
Thank you. Going further, immediate induction of delivery in any case. We are talking of monochorionic.
Fetal anemia.
Fetal anemia. Okay. In a dichorionic twin, preterm delivery induction is not recommended. Do you agree?
Yes.
In a dichorionic, totally different. And in a monochorionic twin pregnancy also, immediate labor induction is not recommended.
Immediately, no, but
I
after.
will wait for signs of anemia to develop and then if need be. You agree?
Yes.
Yes. Any other comments from any other if somebody else has joined? Or we will
Sir, basically, what fetal medicine people and they advise about Quintaro staging and all for the complications associated with monochorionic twins, and definitely we have to follow those guidelines and go ahead with this.
Yes, madam. That fetal medicine people will do. You and me are generalists. આપણે generalist છીએ. Typical દિવસમાં in a particular day, typical day, I still measure symphysia fundal height, do a 11 to 14 week scan, do a TLH and also suture and episiotomy. This is
Sir, I also do everything. I also do everything.
Also, Deepak Bhai also, and all this is being done by Nalini Ben students in the wards. So
Sir, we
all
also do.
generalists.
Sir, we also do.
If there is a fetal medicine expert, if you are one, these are the cases you can shift to them. Lest we can manage all, nearly all. That is my confidence building to all of you. Good that
and one more very simple thing.
Shift.
Yeah, one more very simple thing I will say is the intrahepatic cholestasis of pregnancy, which is a very simple thing and largely forgotten.
Good. And now an additional feature in that, more highest seen in the eastern part of the country. Highest seen data-wise. Okay.
In our practice at PGI, we saw this very, very commonly because initially.
Yes, madam, but data-wise,
yeah.
I'm not doubting your data. I'm just telling you that data-wise, national big data has come, which has shown that this is an association. These are not causations, please. So they found, okay, fine, data, okay. Just an additional feature. Yes, cholestasis of pregnancy, very important. Hormones playing the trick, fine. So friends, to sum up.
Can I just
Yes, please.
I would just like to say that if you look at the international data, 40 to 60% of the stillbirths will be unexplained. Whereas if you look at our own data, just 20% of them are unexplained. This is so surprising because most of the cases are because of known causes and preventable causes of stillbirth. This is
Excellent. Your
one
message
point
is
I want to
excellent.
make. Yeah.
I
Another
think your message is
uh,
excellent. You have
the-
silently and subtly given a message that if they are explainable, please try to find out.
Yeah. And then the neuropathological, specific autopsy, which is focused on neuropathology, they have found that there are, hypodevelopment or hypoplasia of brainstem nuclei. And there are also they have found functional alterations in neurotransmitters like acetylcholine and serotonin, which will affect the respiration of the baby. So they have been implicated in unexplained stillbirths. Channelopathies and long QT interval you have actually discussed in quite a detail. But what I just wanted to know specifically emphasize that we have an entity like SIDS, sudden infant death syndrome, and we have an entity like sudden intrauterine death syndrome. So both have been correlated. It's the same problem working in the intrauterine life. And it has been again related to channelopathies and long QT interval and the history of sudden deaths in the family. So the family history will be there in these cases. Another thing is that what I personally like very much is the theory that has been proposed, that is triple risk model, where there is some alteration in the maternal physiology, small alterations like obesity, like a very high BMI or at age, and then subtle changes in the baby like FGR, initial stages. And then there is some precipitating factor or a stressor like the sleep position. She's not lying, she's lying in the on her back. And all these combined together, they may result in an IUD, or she's dehydrated, she had an acute attack of gastroenteritis. So somebody the baby which is already compromised will not be able to withstand all that stress.
That is
So
important.
the
That one
theory
thing
is
which you
something
have
I
added is
really,
very nice.
yeah.
That she is already compromised. It is like a middle class family which is managing its day-to-day finances, and suddenly an expense comes and it goes down. The family goes down. Understandable. Thank you very much. Very nice comments. I would like to end now. The situation is surely very, very baffling. When it happens, this is the face of the obstetrician. 100%. But it is inevitable. You can't accept it. Accept it that it is not always preventable, and so quite often inevitable. Every time this is our bad luck, and our response also has become like this. We try to hit our own self. We are continuously hitting our own self. I did something wrong. I did this. I did that. Pulmonary embolism following total lap hysterectomy in spite of giving heparin. I was told, asked by one of my students, what more? Enough. Stop hitting yourself. We have already been beaten by the mother as well as the relatives. Not necessarily physically, but emotionally, psychologically, which has more effect. And that is where such wonderful teachers help us. Such wonderful inputs which have come top class. Alert, non-negligent, no 400 plus sugar, blood sugar, as Manubai said, after the death is found. Alert, completely in command of what is happening from such panel discussions, from such lectures which have been given, very well informed. I have been seeing this, that there is much more attendance in between. Webinars fell down because everyone wanted personal touch. But now when we see the pictures and reports which we get from all over the country, in a hall of 700, 800 people, 3 people are listening. And all 3 of them are speakers. Whereas in the last webinar which I addressed, God's grace, there were 961 people listening, all sitting at home. So well informed. This is the way for quality information. Well read. Then you can always be happy at the results.
Thank you very much, Pankaj Bhai. It was a wonderful moderation. We all enjoyed it, and I'm sure I'm saying it for all the co-panelists and everyone. Thank you very
A
much.
very difficult topic, but then again, very wonderfully and enjoyably compiled and moderated, Dr. Pankaj sir. Always a pleasure.
Kartikeya bhai, I missed you.
Thank you very much, sir, for a very nice moderation of the panel.
Thank you. Kartik bhai, I would have loved you to be there. Kartik Shastri has just appeared.
Yes, sir.
Yeah,
Sir,
some new things, rarer things you could have brought in. Which we say, Tamkin Ben has, sorry, in Gujarati we say Ben. Tamkin Ben added some rare things. Our Agrawal madam also added certain things as chairpersons. Kartik bhai, you should have added.
amazed my obstetric emergency. I was just privileged to listen everything, including intrahepatic cholestasis, the monochorionic twins, and absolute deliberation from your side, sir. The only issue was I was held up in the labor room, so I could just pay my ears to your talk.
Our bad luck. Therefore, marry an obstetrician wife. She is running. Actually, she is conducting a delivery, and I am sitting here. Thank you. Just in a lighter way.
Sir, his wife is gynecologist only. They are both our students.
Very good.
I was actually very happy to be a part of this panel, joining my teacher Nalini madam as my co-panelist. I would be blessed to speak at least few words on IUFD.
Therefore, it is said before I finish and hand it over. If you have to learn in life, learn from your student. If you have to lose to someone, lose to your children. હારવું તો પોતાના બચ્ચા સામે હારવું ને શીખવું તો પોતાના સ્ટુડન્ટ્સ પાસે શીખવું. And I have had that opportunity. Thank you very much, all of you. God bless you. We can finish it so that I have certain other work to do. We'll be able to.
Yeah, thank you very much, Pankaj Bhai.
So much.
Thank you, Pankaj sir.
Pankaj Bhai and MC Patel, is it okay if I leave? I really got to rush to a social call.
Yes,
thank you very much. It was a
really.
wonderful thing. MC Patel, thank you very much, and all the best to your presidential candidate campaign and all that. We are all with you. Thank you.
Thank you so much, Pankaj sir. It was a wonderful panel discussion. I would take this opportunity to thank our program director, MC Patel sir, as always. Convener, Dr. Monica, my co-coordinators, Dr. Monica Gupta, Dr. Deepika ma'am, Dr. Nivedita ma'am, and Dr. Megha ma'am. Thank you, all of you. Heartiest thanks to our chief guest, Dr. PK Shah, for taking out time, sir, and he could join us for some time. Also, thanks to Dr. Neeraj, Dr. Sudhir, and Dr. Hemant, sir. Thanks to all our speakers, Dr. Neeta ma'am, Dr. Kartik, and Dr. MC Patel, sir, of course. Thanks to the chairpersons, Dr. Jignesh, Dr. Deepal, Dr. Dhiren, Dr. Hinaben ma'am, Dr. Anand sir, Dr. Devraj sir, Dr. Gopal sir, Dr. Kuntal ma'am, and Dr. Puneet sir. It was a wonderful panel discussion. So much to learn. Thanks a lot, Pankaj sir. And thanks to Dr. Neelam ma'am and Dr. Tamkin ma'am for those very, very insightful discussions and some added extra points, as Pankaj sir said. We had a very good, esteemed group of panelists. Thank you to Dr. Devanand, Dr. Nalini ma'am, Dr. Piyush, Dr. Hira sir, Dr. Jigna ma'am, Dr. Deepak sir, Dr. Kartikeya, and Dr. Jignesh sir. Thank you a lot. Last but not the least, thanks Team Corona for giving us the platform to present and have this wonderful academic discussion. I would request and appeal to all of you to kindly support MC Patel sir in his endeavor to become the next president. Thank you all of you. Good night. See you all soon. And the audience.
Thank you, everyone.
Yeah, thank you.
Thank you, sir.
Corona Remedies.
Thank you, sir. Thank you.
Special
Thank
thanks
you, everyone.
special thanks to Pankaj Bhai, making panel as usual very interesting and fruitful, I would say, because it was very a good discussion, and all the panelists were involved in a discussion at depth, I would say, and we enjoyed as usual.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you,
Good
sir,
night,
from
sir.
Corona Remedies. Looking forward to many more webinars with you. Thank you.
Thank you.
Thank you, sir.
Thank you, MC sir.
Thank you.
डॉक्टर
Good night.
निवेदिता जल्दी ठीक हो जाओ.
हाँ, ये पता नहीं मेरा वॉइस रेस्ट नहीं हो रहा है, इसलिए मेरा आवाज ठीक नहीं हो रहा है.
Yeah. Thank you, sir. Thank you so much. All
थैंक
the
यू
best,
थैंक
sir.
यू थैंक यू
Thank you.
आप
Bye.
सबकी दुआ है मेरे साथ
नहीं, नहीं,
थैंक यू
जल्दी ठीक हो जाओ।